All right. Once again, the music stops and we start dancing. So I'm Rick Barron, the chair of the MSG, and once again, welcome to day 2 of the MSG annual meeting. Yesterday's meeting was a huge success. We had 150 people on, and we have 53 on now, but I bet in the next few minutes, it'll really jump up quickly. So Dr. Hanna was supposed to do the introductions with me again today, but his daughter was graduating from Oxford University today, and she was getting first honors, and he had to be there. So he'll probably may join us later. So thank you for participating in the event yesterday. If some of you are signing on for the first day, that's great. Chat with me to let me know this is your first day so I can say hello. I said hello to many of you yesterday. And for those I didn't say hello to, if you want to chat with me to say hi, please do. So remember, this whole thing's being recorded. Let's go to the next slide. So once again, we want to really, really thank our sponsors for helping us put on this great meeting. And so I'm going to repeat this. I did it yesterday, but it's worth repeating numerous times. These are our platinum sponsors, CSL Behring and Dyne Therapeutics. Next slide. These are our gold sponsors, Arginex, Genentech, PTC Therapeutics. Our silver sponsors are Biogen, Sarepta, and UCB. And we have a number of corporate sponsors, which we really appreciate. Alexion, Amylyx, Audentes Therapeutics, Catalyst Pharmaceuticals, Kaba Fusion, New Factor, Optum Specialty and Infusion Pharmacy, Solio Health, and Spark Therapeutics. Thank you all so very much. So just a little bit about the MSG. You know, as I said yesterday, usually Mike and I split this up, or we did it all at once, but we're trying to save time on every day. So we're trying to do about 5 minutes a day on what the MSG is. So in addition to putting on this great meeting, we want you, if you have an investigator-initiated study, or if you're pharma too and have a study, it would be great to get it approved by the MSG, go through the executive committee of the MSG. It gives you a stamp of approval and prestige. You could say on your publications, it's an MSG study, and you can end it at that, actually. It doesn't have to go beyond that. Or you can use some of the tools that we have. So Mike McDermott is our statistics guru. And if a study is approved by the MSG or you're trying to get it approved, he is available to help you develop statistics for this study and with the steering committee study design. And then you put Mike in your grant, and if it's funded, then he's supported that way. But up front, there's no charge. The data management has been done out of Rochester if people want, but now there are other options. And Russ Waitman moved from KU to MU with me, and he's a data management guru, informatics, RedCap, and I2B2 guy, and his team can help with study forms and develop an informatics management tool. Again, up front, no charge. You put them in the grant, and then they get paid. And then, of course, just have a study having one of your IITs as an MSG study. There's career enhancement and a chance to hang out with us. Next slide. So the way you submit a study to one of your IITs to become an MSG study, or pharma, we haven't had a pharma do it yet, which would be cool if one of the pharma companies wanted to actually get the stamp of approval of the MSG. I think that would be really cool, sponsors. And it doesn't tie you to us for anything. I mean, it's still your study, but then you can give us updates and this and that. But usually this is for our academic investigators. So you email Liz Polk a copy of your protocol and a letter requesting and a letter of the members of your steering committee. Now, if you need guidance on how to compose your steering committee, I can do that, or Mike Hanna can do that, or Mike McDermott can do that, and by email ahead of time. this is like a paragraph letter. It's short, but you have to have a statistician on there. We want a lead study research coordinator. It's nice if you have a project manager. And then usually you have one or two other co-investigators, et cetera. So we can help you with that. And then it goes in front of the executive committee. We meet by phone frequently and we approve it or not. And if we think it needs some work, then we'll let you know. All right, next slide. Now, so that's been a traditional function of the MSG for over 20 years since Dr. Griggs set it up in the late 90s. Because we've been so successful lately, in addition to funding fellows, and you heard Paloma yesterday, today you're going to hear Renata, we are in a position now where I believe that we can have some funds to support small studies. Now, obviously the MSG studies are usually big ones, multi-center studies, at least 2 or 3 sites, and then you put in your grant to get your statistics and data management. But if you had a real small study at your own site, a pilot study, and you wanted some statistics or data management help, we probably have a little bit of funds to budget that to help you. Also, I think we can help in grant assembly. Many of you know Laura Herbelin, who's been with the MSG and been working with me for 30 years. And she's in semi-retirement now, but she's actually offered to help people assemble all their grant material for submission. She's really expert on that. That's how I got all my grants in over the years. And so we can pay Laura as a consultant to do that. And I'm open for other ideas. If I'm thinking of $5,000, $10,000, $15,000 range where we might be able to help you out with some of these needs. This is a new RIC idea, and I ran it by the executive committee, and they liked it. And so we're going to see where this goes. All right. And if you want to volunteer for anything on the MSG, any committees, be a part of the annual meeting committee, the Shark Tank, we have a fellowship committee now just email me and say you want to be involved, and we'll put you on the list. Or if you want to be up for election for a membership for the executive committee, let me know. All right, next slide. So we like people to be members of the MSG. To attend this meeting, you don't have to be a member. But MSG membership is really for an institution. So if you're at a university and you pay the $500 annual dues, then everyone with you at your university, therapists, nurses, other doctors, are all MSG members. And this has been very successful. If you're an individual one-off somewhere, talk to us and we can work out a way. We don't have it set in stone yet for a reduced rate for those sort of one-offs, but I'm sure we can figure something out. Again, you don't have to be an MSG member to take advantage of any of this stuff. Once you get a study approved by the steering committee, and if that gets funded, then you are an MSG member, and we will really want you to do your $500 annual dues. As an MSG member, this year we really waived the registration fee, essentially. So your annual dues covered your registration fee. I think that's right, isn't it, Liz? It is? Okay, thank you. All right, now, next slide is our impressive list of our current dues paying or almost dues paying MSG members. You all have been doing really pretty good. I've really been impressed. And so paying your dues not only helps with the annual meeting, but with all the other stuff we want to do. and the fellowships, the support that I'm talking about, it all, and then once we go back to being in person next year, it gets very expensive. And that's really where we need our sponsors but in the meantime, we're doing very well, and we can afford some of these other things. So just take a moment, scan the list, see if your name's on it. And if it's not, and you want your name to be on it, then just email me or Liz. Okay, next slide. So this last year, we had 4 new members, universities join. I should have put the list of all the docs and coordinators on here too. But anyway, University of Pittsburgh, Stanford Medicine, University of Massachusetts, and Cedars-Sinai. So welcome to be full MSG members. Thank you very much. And yeah, all right, let's, one other thing, I think I'll mention is that the words are muscle study group, but that goes way back to, the late 90s. And we are more than a muscle study group. This group is focusing on muscle, peripheral nerve, anterior horn cell, neuromuscular junction. And so it's the whole thing. And I know Gordon seemed apologetic yesterday that he was giving a peripheral nerve talk at the MSG. I should have told him he shouldn't have been. That is the function of the MSG now is all 4 areas. We thought about changing the name at one point to the neuromuscular study group, but that would require change in a lot of stuff. Next slide. Including our official name. So, when we moved the MSG from Rochester to KU, when Griggs turned it over to me to run, he was at a private institution prior to that, University of Rochester. I was at a state institution. So I couldn't run funds through as easily the state. And so we set up a 501c3, which is the way to do this anyway. And then I ultimately set up the Walls as a 501c3. I think Niels followed us and set theirs up as a 501c3. And so this is how you should do these things. So our official name is the Muscle Study Group, Inc., established in Kansas in 2016. Our treasurer, thank you, Dr. Demachki, for serving as our treasurer, because the bank is in Kansas City, Commerce Bank. And our official address is the KU address. And we actually have a tax ID number. We don't have to pay taxes as long as we file our tax every year. And every year we have to file our taxes, which are 0. And we have a CPA firm that helps us get that all together. So all the money that we have coming in, we have to account for. So it costs about $5,000 a year for the lawyer and the CPA to keep it as a 501c3. So I'm giving you guys a lesson on 501c3s. It's a bonus today. All right, I see Paloma listening very carefully. Paloma, you'll be setting one of these up soon. All right, next slide. All right, and this is my last slide, meeting information. So again, if you want to ask a question, click on the raise hand. That's actually the best way, although yesterday people were mainly doing it through chats, and our moderators did really well handling that. The mingling sessions yesterday went really well. I got to meet with all of our industry sponsors and many of the members. So let's try to do that again today. And of course, Liz was able to get CME offered. So if you're in the US and you need CME, you can get it through this and you'll get a survey on that. So that's it. So that's opening remarks. I spent too long. I'm sorry. Let's go right to our arimoclomol and IBM trial update. So it's a great, great pleasure to introduce my partner for many, many years, Professor Mazen Demachki, the Executive Vice Chair of Neurology at KU and the Division Director for the Neuromuscular Division at KU. And he has been the heart and soul of the arimoclomol IBM study, along with Pedro Machado, for many years, and we are going to get the update. Dr. Demachki.
Can you see my slide?
Yeah, we can see it, Mazen.
Okay, very good. Thank you, Rick, for the kind introduction. And I would like to present to you a muscle study group study, the randomized double-blind placebo-controlled study of arimoclomol in patients with inclusion body myositis. This study is supported by an R01 by the FDA Office of Orphan Product Division, as well as it's an industry partnership with Orphazyme AS, a great partnership that we've had for several years.
Can you advance it, Mazen, or do you want Gil to advance it?
I did. I think.
Okay, I'm sorry. I'll turn my mute up. Thank you.
Thank you. As far as the background, we know that arimoclomol amplifies the heat shock response, specifically in stressed cells, and that this would promote, in turn, the clearance of intracellular protein aggregates and promote the natural folding of nascent proteins and the refolding of misfolded protein. And that in inclusion body myositis, while this is a complex disease, and while there's evidence of inflammation and degeneration, there's clear evidence of protein aggregation. So our methods was to conduct this international 12-site, multi-center, randomized controlled trial to evaluate the efficacy of arimoclomol 400 milligrams PO/TID after a 20-month exposure in 150 patients with inclusion body myositis, with the patients being randomized 1-to-1 to arimoclomol or placebo, with our goal being comparing the change from baseline in the IBM FRS score. We modeled the statistical plan and the powering of the study based on the pilot data, and we thought that with 68 subjects in each group, we have an 80% power to detect a 1.4-point difference in the IBM FRS at month 20. And therefore, to account for some dropouts, we ended up with the 75 patients per arm. Our primary objective is to evaluate the efficacy of arimoclomol using the IBM functional rating scale compared to placebo over 20 months. There were secondary outcome measures such as the 6-minute walk test, the MTUG, manual muscle testing, quantitative testing of muscle strength, and others. Safety measures from a safety tolerability, looking at laboratory parameters, as well as adverse events, and of course, the Columbia Suicide Severity Rating Scale. This is the study schema. After a screening period, initially here, patients were randomized at baseline to either receiving arimoclomol 400 PO/TID or placebo. Visits were adapted during the course of the study to be monthly in the first 6 months, after which they were every other month up to month 12, then every 4 months after that. And there was at month 20, the end of treatment visit, after which there was a safety follow-up. And during the course of the study, the IBM open label extension became available afterwards, offering to participants who've completed the study to be on arimoclomol 400 milligrams PO/TID. This is the baseline demographics of the study. These were elderly subjects. As you know, patients with IBM are older patients. They're mainly males, as one would expect from the demographics of the patient population. They were a bit on the heavier side, 82 kilograms on average body weight. Most of those patients were clinically defined inclusion body myositis according to the ENMC 2011 criteria. Some of them were clinical pathologically defined. 14% were probable IBM according to the classification. The inclusion criteria admitted all 3 categories. We screened 172 subjects, randomized 152, 74 in the arimoclomol group, 78 in the placebo group. We dosed 151 subjects. There was one subject here that was excluded from the dosing, another subject that was excluded from the ITT population. There was a violation of the inclusion or exclusion criteria in one or the other subject, resulting in that. This is the primary efficacy endpoint representation. The primary outcome is the IBM functional rating scale. This represents the timeline up to 20-month change in the IBM functional rating scale. You can see in the red dashed line, this is the performance of the placebo group. In the blue line, you see the performance of the arimoclomol group. There was a similar decline in the IBM functional rating scale between both groups, and the p-value did not show any difference between those two groups that is statistically significant. Looking at metrics that are secondary outcome measures, such as hand grip strength, there was no statistically significant difference between the arimoclomol and placebo. Knee strength quantitation was no different. MTUG did not show a statistically significant difference. The 6-minute walk test did not reveal that either. And the manual muscle testing was also uninformative towards a benefit for arimoclomol. From a safety standpoint, there were, as one would anticipate with a biologically active molecule, more adverse events in the arimoclomol group, 97% versus 90% in the placebo. Those that are study-related, 84% were more than those that were in the arimoclomol group, were more than those observed in the placebo, which is about 49%. Serious adverse events were well balanced, but when you look at serious adverse events with the lens of relatedness, there were more related serious adverse events in the arimoclomol group, and the adverse events leading to drug discontinuation were more prominent in the arimoclomol group, affecting 18% of the subjects, as opposed to 5% in the arimoclomol and placebo group, respectively. What were those adverse events leading to drug discontinuation? And you see here a representation of those adverse events. There were gastrointestinal general disorders such as fatigue or feeling hot. Investigations, transaminase increase is one of them. Here there's 4 cases of discontinuation due to that. And I'll walk you through some of those more specifically in the next snapshot that I'll provide you. And there was a smattering of other reasons, decreased appetite, syncope, and all different other reasons. However, as far as the transaminase signal goes, in the first 2 to 3 months, the frequency of AST/ALT elevation was higher in the arimoclomol group compared to the placebo. The magnitude of the elevation in the majority of the 7 cases with AST/ALT elevation was in the 3 to 5-fold elevation range, whereas in the there was 1 case each in the 5 to 8-fold elevation range, and 1 that exceeded 8-fold elevation. As far as serious adverse events, as I mentioned earlier, they were well balanced between both groups. But once you looked at relatedness of serious adverse events, those that were more frequent in the arimoclomol group were nervous system disorders, the renal disorders, and vascular disorders, 3, 1, and 1 each. To conclude, this is a negative trial that did not meet its primary and secondary efficacy endpoints. The progression of the placebo group was surprisingly lower than modeled as part of the trial design. There was a higher incidence of adverse events in the arimoclomol group compared to placebo. The distribution of those serious adverse events was comparable between the 2 treatment groups, but there were more adverse events leading to treatment discontinuation in the arimoclomol group, and there were no important safety concerns. I'm really grateful and thankful to the investigative group in the US and UK at University College London, and the leadership team of the study thankful to Orphazyme for supporting this study, and thankful to FDA OPD for the grant support through an R01 mechanism, but also very grateful to the research subjects that contributed and participated and donated their time to make this study possible. And a final shout out to the project managers, research coordinators at the sites that are the foot soldiers for this study. Thank you very much for your attention. I'm open for questions.
Thank you, Dr. Nemachki, and thanks for you and for Pedro and the team at Orphazyme for doing an amazing, amazing job running this complicated international study. I just impressed every week on how you all were doing it. And I felt like Mike Hanna and I just sort of started the ball rolling. We gave you guys a push and then you were off and running. So we were very disappointed with the results, but it was well run. Any questions for Dr. Nemachki? I don't see any in the chat room or hands raised. Do I, Gil or Liz? Okay, so I know Dr. Nemachki and the Orphazyme team and Pedro will be busy getting this published soon. And again, thank you very much, Mazen.
Thank you.
All right, now I'm going to turn this over, I think, to Shafiq Karam.
Yeah, hi.
Shafiq, I'm going to go on mute. Thank you for moderating the next session.
Yeah, thank you, Rick. Thank you, Mazen, for your update on the arimoclomol and IBM. And as Rick mentioned before, well, the name is Muscle Study Group. We do everything really in the MSG, all type of neuromuscular disorder. And I'm going to prove you now by introducing the next session, which is going to be the inflammatory neuropathies and outcome measures with a group of great speakers. And we'll start with Dr. Dick from the Mayo Clinic, who's going to talk about the spectrum, or expanding the spectrum of a disorder he described maybe almost 10 years ago with CISP. Used to be part of the CIDP, and now in the newer classification, it was dropped. So Dr. Dick, please go ahead. We're excited for your talk.
Thank you very much. Can everyone hear me? And you can see my slides? Good. So, yeah, I was going to say the same thing, that this is my first muscle study group attending since I'm a nerve person, but I'm excited to be with you, and I appreciate the invitation to talk to you about chronic immune sensory polyradiculopathy and the CIS plus syndrome. These are the things that hopefully we'll be able to do by the end of the talk. All right, so inflammatory neuropathies. Inflammatory sensory neuropathies include Sjogren's-associated sensory neuropathy, paraneoplastic sensory neuropathy, sarcoidosis, vasculitic neuropathy, the paranodopathy, and sensory CIDP. Shino and colleagues described sensory CIDP in 1992, describing pure sensory neuropathy, a progressive course, high spinal fluid protein, electrophysiological evidence of demyelination on motor and sensory nerves, as well as on nerve biopsies, and they felt it was sensory CIDP. In 2004, Michael Sinreich and we described a focal neuropathy that exclusively involves the sensory nerve roots proximal to the dorsal root ganglion, causing sensory ataxia. This was an inflammatory demyelinating neuropathy that was treatable, and we called that CISP, and we felt that that was a restricted form of sensory CIDP. So this is the dorsal root that it selectively involves. We described 15 patients, average age of 63 years, large fiber sensory symptoms predominated. They all had gait ataxia. In all 15 patients, the course was chronic, and the average time was 5 years. All 15 patients had altered large fiber distribution with gait ataxia. 14 had reduced or absent reflexes. None of them had weakness. 13 of 14 who had spinal fluids taken had elevated CSF protein with an average of 83. By definition, all nerve conduction studies in EMGs were normal, but in quantitative sensation, there was large fiber sensory abnormality. 12 of them had somatosensory evoked potentials performed. They often showed prolonged N13 from the cervical root, or N9 to N13, and an interpeak latency, showing that it really was the root that was involved. The lower limb tibial studies often were non-localizable, but it did show some abnormality in somatosensory pathways. 5 of the patients had thickened lumbar rootlets on MRI. And here is an example of those. 3 of them had rootlet biopsies, and we compared those rootlet biopsies to controls, found that the density was really fairly similar, but there was a marked altered size distribution so that the patients with CISP had fewer large myelinated fibers. And so the top here is a postmortem control, and you can see there's a large fiber peak, and all 3 of the CISP patients had fewer large fibers, and the large fiber peaks essentially were gone. We did electron microscopy and found frequent onion bulb formation. Onion bulbs are stacks of Schwann cell processes, evidence of chronic demyelination and remyelination. 6 severely affected patients were treated with IVIG or steroids. All had marked improvement of the sensory ataxia. 4 returned to normal ambulation, where 2 others had meaningful improvement. We published that in Neurology. Now there's a problem that has arisen. Since CISP's original description, we've recognized patients with a very similar clinical syndrome, but with mild distal weakness and mild nerve conduction or EMG abnormalities. And these often suggest an axonal pathology. And so those patients don't meet our criteria for CISP because the neuropathy is not only at the sensory root level. And how should we classify these patients? And so we propose the term CISP plus as a term for these non-pure CISP cases. And I'm going to give you an example of a case. This is a 54-year-old man who presents with progressive ataxia. 14 years earlier, his right foot became numb, followed 6 months later by numbness of his left foot. Progressively, both of his feet became numb. He couldn't run anymore. He was ataxic. 10 years earlier, his hand became numb, right more than left. And over the last 18 months, he lost dexterity of his hands and he couldn't type anymore. A year earlier, he developed double vision. He had a left cranial nerve 6 palsy. 3 months earlier, he developed the flu-like symptoms. And then his symptoms, neurologic symptoms, dramatically worsened. His numbness worsened. He could no longer walk. He denied pain or weakness. His history was significant for HIV positivity on antiretroviral agents. He had Hashimoto's thyroiditis. On examination, he had the left cranial nerve 6 palsy. Otherwise, his motor examination was normal. He was areflexic. On sensory examination, he had reduced pin and touch, absent joint position sense and vibration, both in the right hand and the feet. His gait was markedly ataxic. He couldn't tandem walk. He had a Romberg sign. Nerve conduction studies, EMG, showed an axonal sensory motor polyradiculoneuropathy. So unlike CISP, he had abnormal nerve conductions in EMG. Quantitative sensation showed abnormalities to touch, vibration, where cooling and heat pain were normal. So this is a large fiber abnormality. His median somatosensory evoked potential showed a prolonged cervical N13 and N9 to N13 interpeak latency, and that localizes the process to the sensory root level. His laboratory evaluation was negative. His CSF protein was mildly elevated at 67. MRI of the lumbar spine showed thickening and enhancing nerve roots of the cauda equina. Lumbar plexus MRI showed T2 hyperintensity and large bilateral lumbosacral plexus. And you can see there thickened roots as well as thickened femoral nerves. And here is his plexus MRI. We did a superficial radial nerve biopsy. His density was fairly normal, but he had reduced large fibers. He had frequent small fibers and frequent regenerating clusters. The arrows are pointing at regenerating clusters. He had frequent endoneurial inflammation. You shouldn't have inflammation in the endoneurium because the blood-nerve barrier. And on electron microscopy, he had frequent regenerating clusters. So most of his features suggest CISP, his severe sensory ataxia, but his nerve conductions in EMG suggest an axonal polyradiculoneuropathy. And we wondered what role has HIV played in all of this. How should we treat him? We decided to give him IVIG. He came back after 6 months of weekly IVIG. His gait ataxia was markedly better. It stopped falling. His hands and feet numbness was much better. He regained his ability to type. He resumed working. His median somatosensories returned to normal. So how should this case, another case like it, be classified? It's not only confined to the sensory root. Nerve conductions EMG suggest an axonal process. There's involvement of the pelvic nerves on MRI. There's involvement of the superficial radial nerve on nerve biopsy. His neuropathy improved with immunotherapy. We believe that the HIV disease was not the driving factor. And it seems like this case really is a form of CISP with spillover into motor and sensory nerves distal to the dorsal root level. So we did a retrospective search in Mayo Clinic cases from 1986 through 2019. We reviewed the records of 16,000 patients. We identified both cases of pure CISP as well as CISP plus. And we wanted to compare CISP and CISP plus cases in terms of clinical, electrophysiological, laboratory, radiographic, pathological, and response to immunotherapy. To be called pure CISP, you had to have a sensory syndrome without weakness with normal nerve conduction studies, imaging that excluded other pathology, and either SSEP or imaging abnormalities consistent with nerve root involvement. To be CISP plus, it was a predominant sensory syndrome with mild distal weakness allowed, and you could have mild nerve conduction study abnormalities. And again, imaging excluding other pathology and SSEP or imaging consistent with nerve root involvement. And so this is a pictorial representation of the difference between CISP and CISP plus, where CISP is only dorsal root and CISP plus is dorsal root with some spillover into other nerves. So we identified 44 CISP plus, 28 pure CISP. They were men slightly more than women. Average age was around 60. Their symptom duration was 4 years for CISP plus 2 years for CISP. Both had a sensory predominant presentation. Both had gait imbalances, very prominent features. Slightly more than half in both cohorts had falls. Prickling was common, about 3/4 of both. Pain was very uncommon in both. Use of gait aids was slightly less than half in both. Use in wheelchairs was uncommon, but occurred in both. Large fiber sensory loss on examination was there in almost all cases in both. Absent reflexes were there in almost all cases in both. Gait ataxia was very common in both. Romberg signs was there in about 2/3 in both. Abnormal tandem gait was there in about 2/3 in both. Mild distal weakness happened in 75% of CISP plus and didn't happen at all by definition in pure CISP. Again, by definition, all pure CISP had normal nerve conductions in EMG. All CISP plus cases had mild nerve conduction studies abnormalities, including prolonged F waves, reduced CMAPs, reduced SNAPs, slowing of motor conductions, slowing of sensory conductions. No CISP plus cases met electrophysiological criteria for CIDP. So by the traditional criteria, you wouldn't call any of these CIDP. Needle examination was normal in most CISP plus in 86%. 14% showed a mild motor polyradiculopathy, including the case that I presented. SSEPs showed abnormality in about 3/4 of both. The median abnormality occurred in about half in both, with the prominent prolonged N13 or N9 to N13 suggesting root pathology is the most common. Lower limb SSEPs were abnormal in 90+% in both. And in the CIS plus, in some of the cases, there were a prolonged N22 in the tibial, suggesting lumbar root pathology. And here are examples of pure CIS and CIS plus localizing it to the root. Quantitative sensation was abnormal in close to 90% in both. There was a large fiber abnormality more than small fiber abnormality in both. 11 CIS plus patients had nerve biopsies, 3 lumbar root, 2 fascicular static, 6 distal cutaneous. Teased fibers showed increased rates of segmental demyelination in all. It was more prominent in the proximal biopsy. So the average in the rootlet was 21%, where the static was 15%, where in distal it was uncommon at 3%. We did morphology on all 11 biopsies. Here's an example that the teased. At the roots, there's onion bulb formation. The static, you can see segmental demyelination. In D and the sural, there's some segmental demyelination, and in E, there's some temaculi, which is myelin remodeling. The main abnormality was reduced density of large myelinated fibers, which was more pronounced in proximal root biopsies. There was a loss of the large fiber, and so there's a unimodal fiber distribution. Onion bulb formation was common in the proximal biopsies, 2 of the root, 1 of the sciatic, and abnormal degrees of endoneurial inflammation were seen. So here is scattered endoneurial inflammation. Here is an example of a rootlet biopsy, postmortem on the top, on the bottom, 1 of the CIS plus, and you can see loss of large fibers. Here are another 2 rootlet biopsies, and again, you can see loss of large fibers, and the arrows are pointing at onion bulbs. Here are regenerating clusters and rare onion bulbs in distal biopsies, and again, loss of large fibers. And this is a sural. The top is a normal. The bottom is 1 of the CIS plus showing loss of large fibers. Electron microscopy again showed onion bulb formation, most prominent in proximal biopsies. So the rootlet, you can see large onion bulbs, and the sciatic, not as large, but frequent onion bulbs. And then regenerating clusters. And the bottom is a sural that shows a small onion bulb. CSF showed elevated CSF proteins in 90+% in both groups. The average was 67 in the CIS plus 71 in the pure CIS. Pleocytosis was rarely seen. There was abnormality on imaging. On root MRIs, there was abnormality. On plexus MRIs in the CIS plus, there was also abnormalities on the MRIs. And so here are some of those MRI abnormalities in the CIS plus patients. There were concurrent other diseases. 3 CIS plus and 3 pure CIS had concurrent MS, the 1 case of HIV, and then there were contact and 1 antibodies in 1 CIS plus and 1 pure CIS patients. We treated many of these patients most commonly with IVIG, and 84% of CIS plus, 93% of pure CIS had improvement. Over half of them went back to a normal neurologic examination, and many of them stopped needing gait aids to walk. So we have found striking abnormalities between CIS and CIS plus in regards to clinical features, SSEP abnormalities, QST abnormalities, CSF findings, MRI findings, pathological findings, and response to immunotherapy. We believe that CIS plus and CIS should be classified together as a sensory CIDP variant. Both respond to immunotherapy, mostly IVIG, especially the sensory ataxia, and approximately 1/2 of both CIS and CIS plus patients return to normal neurologic examinations. It's important to recognize that both CIS and CIS plus they're both treatable. It is challenging to diagnose both of these. CIS has normal nerve conduction studies. A lot of these patients get called hysterical. CIS plus has falsely localizing findings because the nerve conduction EMG suggests an axonal pathology. Consequently, physicians need to be aware of these to diagnose them. We published this last year in neurology. So in conclusion, we have previously described a syndrome of sensory ataxia localized to the sensory root, proximal to the dorsal root ganglia, called chronic immune sensory polyradiculopathy, or CISP. We now recognize a non-pure form of CISP where there's mild distal weakness or abnormal nerve conductions in EMG that don't meet the criteria for CISP. We call that CISP plus. CISP and CISP plus both present with sensory ataxia, elevated CSF protein, slowing of SSEP latencies, thickening of dorsal roots on MRI, large fiber abnormality on QST, inflammatory demyelinating changes on sensory nerve roots and nerve biopsies. The major difference is that CISP plus has mild distal weakness, nerve conduction study abnormalities, and pathology on non-rootlet biopsies. CISP and CISP plus can be easily missed by conventional evaluation and need to be specifically considered to be diagnosed. Both CISP and CISP plus patients have improvement of their sensory ataxia with immunotherapy, especially IVIG, and warrant therapeutic trials. CISP and CISP plus are both due to focal inflammatory demyelination, and both are restricted forms of sensory CIDP. A lot of this work was done by our fellow Dr. Shahar Shali and others, so I wish to thank them and thank you all for your attention.
Thank you, Dr. Dick. Excellent talk and very helpful since, as you mentioned, some of these patients may be missed and they can benefit greatly from treatment. So thank you for telling us about this. We have a few questions. I think Mazen raised his hand first. Mazen, do you want to go on and live and ask your question?
Yes, thanks for this excellent presentation, Jim, and for defining better this phenotype of CISP plus. I have a couple of questions. One of them has to do with the EAN PNS revision criteria.
Yeah.
They were specific to CISP. Do you agree with that? That's one question. The other is, was peripheral nerve ultrasound performed on some of those patients to see if there was, now with the inclusion of ultrasound, the sites of swelling to support demyelination? And the final question is, if they fail IVIG, as all patients do not respond to it, do you have a second-line agent that's your preferred agent that you've seen successful in those patients that are really tough to treat?
Well, a lot of good questions. So Maz and I considered asking you yesterday during your presentation of the new criteria about CISP and CISP plus. I had a lengthy conversation with Peter Vandenberg about this very issue. So 10 years ago, they included CISP in their criteria for CIDP as a CIDP variant. Now they no longer include it. And I asked them why they don't include CISP as CIDP. And the answer is, well, it's only confined to the root, which I think is a silly answer personally. Because I don't, CIDP always has been a polyradiculoneuropathy. So in some cases, it predominantly involves the root. And in fact, the pathology of both Guillain-Barré and CIDP have always preferentially involved proximal nerves. So this idea that because pure CISP is purely a polyradiculopathy and doesn't involve distal nerves means it's not CIDP, I don't agree with. I mean, straight out, I just think that's wrong. His answer to me about CISP plus is, well, because it spills over into distal nerves, probably CISP plus would be considered by us to be a form of CIDP. But the problem I have with that is that all the electrophysiology doesn't meet their electrophysiological criteria for that. And, we're not going to go and biopsy roots in most of these patients to prove that. I mean, that is something that we can do at academic centers to really understand the pathophysiology of a disease, but this is not something we're going to be doing routinely on evaluation for patients. So, I just think that you need to keep open to it and then strongly, and then think about what you can do, whether it's SSEP, imaging abnormalities, imaging with MRIs, things like this to try to show that it's not just this trivial peripheral neuropathy that you see on nerve conductions. We do ultrasounds at Mayo Clinic. I've been personally much more involved with doing MRIs to image nerves. So I have not done ultrasounds in the nerves of these people. I've done much more MRIs on these people, but I think ultrasound's a good idea. And oh yes, your last question about treatment. IV methylprednisolone and IVIG are my two first treatments of choice. So I would go with IVIG first, and if they don't respond to that, I would do pulse IV methylprednisolone.
All right, thank
Thanks,
you,
Jim.
Mazen and Jim. And Jeff Allen will be talking about the updates about the 2021 EAN BNS CIDP guidelines. So we also have a question from Gordon. Gordon, do you want to go live and ask your question?
Sure. Thanks, Jim. That was a fantastic talk, not unexpectedly, and I completely agree with your comments on diagnostic criteria. I'm currently fighting with a payer right now to get coverage for IVIG for a patient with CIS plus, and they obviously don't want to because they don't meet the formal criteria. I'm curious if you look for perinodal antibodies in these patients. I have a patient clearly has CIS plus using your kind of criteria for it, who has a neurofascin 155. And so do you see this as a common overlap? I got the sense from your presentation you actually weren't finding that.
Yeah, so this is mostly a retrospective study. So the answer is most of them didn't get tested for it. As I pointed out briefly as I'm running through all my slides to keep on time, we had one CIS plus and one CIS with contact and one antibodies. There were none with neurofascin 155, but again, the minority of these patients were tested.
So we have probably the time for one more question. I'll take the one from Gil, asking that this disconnect seems to preferentially affect the large fiber rather than the small fiber and autonomic. There's not a lot of pain, despite the fact that there's a lot of inflammation at the nerve root. So do you have any comment on that, Jim?
Yeah, I do actually. So thank you for the question. This is, I'm a sort of a simple nerve pathologist. And so this is a big point that I make to my fellows when I'm teaching about CIDP in general, because I see all these patients who come to me with these pain syndromes and their local neurologists say they have CIDP. And yes, CIDP can have pain, but most CIDP really doesn't have a lot of pain. And I think of it as that these are demyelinating neuropathies. So what fibers have the most myelin? Large myelinated fibers have the most myelin. So what do you expect CIDP patients to present with? You expect them to present with weakness, and you expect them to present with sensory ataxia. And so, in fact, that is what they tend to present with. Now, there are exceptions to this, of course, and the CIS plus and the CIS fall right into that. They are mostly large fiber abnormality, and I think it has to do with the fact that these are demyelinating neuropathies and the largest myelinated fibers are affected. Now, I agree that's a fairly simplistic way of thinking about it, and it's probably much more complicated than that, but that is useful to me.
Okay, I was told I can do one more question, two more questions very quickly. Is there an indication that CISP start as CISP and then progress to CISP plus? Have you seen that? And then the other one, maybe you can answer at the same time. Do you see those more common in people with diabetes?
Well, so yes, I've seen some cases that start as pure CISP and then evolve to CISP plus. That's not the most of them, but we're sitting in the middle of a cornfield. So I think a lot of these patients have had symptoms for a long time before they come here. And so when we're evaluating, they usually fall into one or the other. Most of them were not, until once they get evaluated, we follow them over time. But before they're identified, we don't. So I haven't seen a lot of that, but I have seen some of that. As far as diabetes didn't seem to stand out as a major risk factor for either of these conditions.
Yeah, and I can imagine diabetes can complicate a lot of your findings.
Well, I think diabetes would make a lot of them CIS plus where they may otherwise have been pure CIS.
Okay, thank you so much, Jim. That was great. And I think we have a great way to follow up on this talk by looking at something that's pretty challenging for us who treat CIDP and Guillain-Barré syndrome. We're going to talk with Carissa Gable on the biomarkers and see what type of research she's doing in those. Carissa?
Thanks. Hi, thanks for inviting me. Can you hear me? Okay. Okay. How about now? Okay, thanks. Thanks for inviting me to talk about this. So I'm going to talk about biomarkers in immunology and CIDP. So just a brief outline. I'm very briefly going to touch on diagnosis and management just for the context of this discussion and where we're at with the current state of biomarkers or surrogate biomarkers and the use of that, and then how immunology could play a role potentially and the relevance of that, and a little bit about my work and research recently in that area. So just a brief background, of course, this is a rare disorder and the diagnosis is a combination of clinical and electrodiagnostic and laboratory features. And the recent revision of the guidelines will be discussed after this. And then typical kind of clinical pattern would be the progressive or relapsing symmetric proximal and distal weakness in the upper and lower limbs and sensory involvement of at least 2 limbs over time. And those variants of distal, multifocal, focal, motor, and sensory. So management-wise, as you know, IVIG and steroids are often useful for the first-line treatments as well as plasma exchange, although that's a little more difficult sometimes with maintenance. And about 80 to 90% of patients do respond to 1 or more of these. In about 3 to 6 months, you see the most improvement. But what does benefit of treatment really mean, and how is that really defined? And I think that's objective improvement is really key, given the consideration for the high percentage of placebo effect that's been demonstrated in multiple clinical trials in this area. And really, ultimately, that ends up leading to overtreatment, which is basically a risk of those treatments as well as a cost. And so I think that's where biomarkers play a role in potentially guiding that treatment a little more clearly. And so just to take a step back and say, what is a biomarker, or what would that be, or what would you ideally want? And it would be something that would define an objective, quantifiable sort of indication of where at that snapshot in time of disease activity, where you're at right at that moment in time for the patient. It would be accurate and reproducible. It could be useful diagnostically, which is currently what we kind of have right now, or longitudinally, which would be ideal to help guide treatment decisions. Ideally, it would reflect treatment effect, and sometimes maybe you don't have like a true biomarker, which is tissue-based, sort of reflective or serologic test, but you could have a surrogate biomarker, which is kind of what we have now, that we'll discuss a little bit later, and that reflects disease activity, but isn't like reflective of the disease activity at that current moment in time. And so what we have at this point is, of course, electrophysiology, so that's clearly very important for the diagnosis, and helpful in circumstances where patients have improved and they're maybe off treatment and then they decline again or relapse, or there's other contributing factors. It's not clear if it's a true relapse or not, at which point you could repeat those tests and see. And so that's kind of the use of that at this point, although the clinical improvement is often, the electrophysiology often lags behind the clinical improvement. And so you can't routinely use those to give you an idea of the current disease activity state for longitudinal treatment decisions. And so you also have imaging findings where MRI can show focal enlargement at the nerve root or enhancement. There are ultrasound findings as part of the diagnostic criteria now that can show brachial plexus enlargement or proximal median nerve enlargement. And those are helpful diagnostically. And then, of course, of recent times, we have these subset of patients, which are 10% of CIDP patients, have a unique clinical phenotype, but also have autoantibodies against neurofascin or Contactin or Caspr-1. And that's been helpful because that does guide treatment decisions. And so that's important finding. Other explorations, just to give a background of what's been looked at before to try to find something like this would be, there are some clinical trials looking at longitudinal monitoring for ultrasound and looking at the focal enlargement. And some small studies have shown that treatment does reduce the size of the nerve, but larger studies need to be done in order to really use that routinely in clinical practice. There's been a lot of discussion about serum neurofilament light chain, which is a structural protein. It's not specific to CIDP, so you can see it with any kind of axon damage with diabetic neuropathy or amyloid neuropathy that elevated in that disease and responds to treatment, and the titers go down. It is useful and has been studied in CIDP patients who have naive untreated disease. And so in those patients, they have elevated serum levels and they do go down with treatment. So that's kind of an exciting area that can be further explored. There's been some investigation in the past, FC receptor modulators and the impaired inhibitory effect of these FC receptors on B cells that just promotes more inflammation. Ultimately, there's been some investigation into B cells with CIDP and MMN after treatment with IVIG. The plasma cell frequency will decline, while the overall numbers remain unchanged, and some investigation into looking at IgG levels and does that correlate with disease activity, which it does not. And so, ideally you'd have some kind of myelin marker that you could measure that we don't have. There's been some report of some markers in CMT1A, and then in the spinal fluid of patients with CIDP, there's been some elevated levels of CSF sphingomyelin, which is a myelin-enriched lipid, and there are higher levels of that in patients with active disease as compared to patients with stable disease or healthy control. So it's kind of exciting, but not quite where we need to be. And so what we're really left with at this point is a clinical exam to help guide management and metrics, which you're likely familiar with the disability scales and grip strength and timed up and go and quality of life measures that can help. But really what we're looking for is something that's more than just a test of treatment or tapering medication and waiting to see what happens. And again, there's that high level of placebo effect that can play a role in treatment decisions, and we're trying to find something more specific to help guide management over time. And just as a case of a patient that I saw who's a 27-year-old with no prior medical history, and then he had gradually progressive sensory loss in the feet that progressed upwards to the knees, a tremor evolved along with marked difficulty with walking. He had proximal and distal weakness of the upper and lower extremities that progressed over a period of 3 months. His imaging was rather unrevealing, but his nerve conduction studies did help support meeting definite criteria for CIDP. So he started on treatment with high-dose prednisone and had a little bit of improvement, not that much though. So he was also started in addition with IVIG treatment, still not that much improvement. So he came to see me, and at this point, he had areflexia and some coordination deficits, some sensory loss, and some proximal and distal weakness, as well as a steppage gait. And so because of his sort of minimal improvement in response to treatment, I sent anti-neurophesin antibodies, which were positive, and that goes along with the spectrum of having really elevated protein as well in the CSF. And so from that point, just kind of his baseline outcome measures that we had obtained, where he was 37 out of 48 for rods and 4 for his NCAT score, grip strength not quite on par with what his age should be having, and then quality of life really not too good. So he was treated with rituximab, 1,000 milligrams, followed by another 1,000 milligrams given 2 weeks later, and tapered off the prednisone and IVIG as those weren't really working. And after a couple months, his reflexes came back, his strength improved. He had just a little difficulty with tandem gait, but otherwise was doing much better. And his outcome measures at this point also went in the similar direction as his clinical exam, which is helpful. Which improved ROD score, now 46 out of 48, and NCAT of 1. His grip strength also improved, and his quality of life was much, much better. But at this point, what the path forward with respect to continuation of treatment, do you retreat him on a schedule of every 3 months? Do you retreat him based on his B cell count levels, and what percentage of B cell recovery does he have to have in order to retreat him? Do you retreat him based on his clinical symptoms? There's really no really guidance for monitoring of effect. And that's where I think, you can have these outcome measures that define minimally clinically important differences and use those as a guide. And even if the measures don't quite meet those cutoffs, you can still follow the trends for particular patients. But I think ultimately the problem becomes when those trends are a little bit disparate or they aren't helpful in guidance. And then so that's where you would really look for something that was more reflective of disease activity or directly predictive of a therapeutic response. And so that's where I think immunology plays a role, potentially, of guiding that to develop some kind of immune signature marker that you could follow over time. And so just to take a brief snapshot into what's understood about immunology CIDP, it's really heterogeneous, as is the disease, and there's a diverse mechanism of action that includes macrophage-mediated and antibody and complement-dependent and independent mechanisms of demyelination. There's a loss of peripheral tolerance of T regulatory cells are really critical to maintaining that immune tolerance and preventing autoimmune disease by suppressing self-reactive T cells. And so it's been reported back in 2008 and 2009 about, these effects of T regulatory cell function impairment in patients who are off treatment, the frequency of cells were similar to healthy controls. And then there's another study that demonstrated patients with active disease who are on treatment also had suppressive functional capacity reduced and frequency of T cells reduced. And there's been mouse model support of T regulatory cell involvement in autoimmune related neuropathy as well. CD4 and CD8 and B cells all play some kind of role. CD4 cells, there's more understood about that. There's definitely been reports of increased inflammatory cytokines. The interferon gamma, the IL-17 ones are the most talked about, and then their infiltrates into the nerve biopsies themselves that have been seen, as well as mouse models supporting that role in the disease process. CD8 T cells are also increased in biopsies. There's not as clear a translational effect in mouse models, but it definitely plays a role. And B cells have been not fully determined the role. Of course, there's a treatment effect of B cell suppression, not just in patients who have paranodopathies, and plasma exchange seems to work. So there seems to be some kind of humoral response there. And we do have the discovery that IgG4 autoantibodies against paranodal proteins and nodal antibodies. So that's promising, but not quite fully developed investigation. And then there's been some investigation to C5a upregulation and complement deposition on the nerve biopsies as well as proteomic studies that show an increase in autoantigens against anchoring junction proteins in CIDP patients. And lastly, this idea or concept of developing T cell repertoires or immune signatures that you could follow potentially over time. So a little bit about some of the work that I've done in the last year on this. So we conducted a kind of comprehensive immune profiling study of the innate and adaptive immune system with a specific focus on evaluating B and T cell responses between 25 CIDP patients, 25 healthy controls, and 25 patients with inherited neuropathy with genetically confirmed CMT. And then we performed flow cytometry and in vitro experiments to kind of comprehensively quantitate B and T cell subsets with respect to the frequency and the regulatory cell functions. And what we saw here, our patients were all on treatment of various kinds. The frequencies of the CD4 T cells were higher in CIDP patients compared to healthy controls, which has been seen previously. And the frequencies of CD8 T cells were comparable among the groups, which may reflect a treatment effect. We also saw what hasn't been seen before, and to this degree, was an increase in central memory cells in the CD4 and CD8 T cells, and that specifically is a very large effect, which indicates that there's those central memory cells sort of home into the peripheral lymphoid organs and then are there to be reactivated. So there's a very significant increase in those. We did see that there was an increase in IL-2 and interferon gamma pro-inflammatory cytokines. IL-17 that's previously been reported to be very elevated and active CIDP was really comparable amongst the groups, which I think might reflect a treatment effect as well. The CD8 T cells also showed an increase in pro-inflammatory cytokines, and uniquely, this polyfunctional CD8 T cell that had a number of different cytokines, kind of pro-inflammatory ones, produced all at once, including the interferon gamma, TNF-alpha, and IL-2. We also looked, as was previously investigated too, and showed that T regulatory function, it was impaired. In our patients, the frequency of the number of T regulatory cells was the same, but the function was impaired, so they had an inability to suppress inflammation. And we also saw a subset of those CCR4 T regulatory cells or effector T regulatory cells that showed that are more associated with a strong migration toward inflammatory sites. And so that was a subset of those cells frequency that were increased. We looked at B10 regulatory cells, which were no different between all the groups in any of the subsets. And sort of the summary of all of that, and I didn't present the innate or immune system data, but for our patients who were on treatment, there was no difference in the aspects that we looked at amongst the innate immune system. There was a prior study that demonstrated that patients who were off of treatment had an increase in monocyte number, pre-macrophage states. So that was an interesting finding. Our overall findings show that there's a shift towards a Th1 or cellular immune response. And essentially what you have, even in these patients on treatment, is a pro-inflammatory state with these, and then an inability to suppress that inflammation in summary. So I think, obviously there's a lot to be further investigated here, and ultimately, the cytokine profiles and subsets would be ideal to follow over time. They're clearly abnormal, even in patients on treatment. And if there was a way to quantify that and create sort of titers you could follow, but the clinical phenotype would have to be very specifically defined. There's been some studies that even show the differences between atypical and typical CIDP have differences in their subsets of T cells and cytokines that are expressed despite being on the same treatments. So I think that will be something to look at further in more detail. I think that it's promising the potential to use serum neurofilament light chain longitudinally. And then as far as the case that I presented with the anti-neurofascin antibody mediated paraneuropathy, it remains to be seen or further investigated if the B cell counts could be helpful in any way for guiding treatment as sort of a biomarker. So in conclusion, I think ideally finding something that can be indicative or directly reflective of disease activity or therapeutic response would be ideal. And ultimately probably won't be the only one thing that you use to guide treatment decisions, but probably likely a constellation of multiple outcomes and tools for clinical care rather than any one measure. So thank you.
Thank you, Carissa, for this excellent talk. We do have a question, but I think you answered it already. It was from Dr. Lay asking about, since there was a profound oligoclonal response and T cell activation, have you looked at measuring CD4 and CD8 plus? And this is basically what you did. And the question is treatment management. And I think you alluded to that, unless you want to add something to that question.
No, I think that, covers it. Yeah.
So, and then you mentioned, I think one of the challenges for folks who treat CIDP is to determine is the disease active or not. And from what you showed, some people who were on treatment seem to have kind of less markers. Do you think you can, while people on treatment, predict if you stop the treatment to take a break, they will relapse, or do you think we're just still early on in this?
I think it's still a little bit early on, but I think that would be the goal, ideal. Mm-hmm. Yeah. Mm-hmm.
Okay. Do we have any other questions from the group? Okay, well, thank you so much, Carissa, for being here. I think we're going to transition to Dr. Allen now, who's going to tell us about the updated guideline for CIDP. You know, the EAN and PNS guidelines are the one that we use the most for diagnosis of CIDP, and they haven't been updated for a while. So Jeff Allen and his group recently published an update on that, and I think we're very excited to hear from him about what's going on here.
Thanks very much, Shafiq. Can you see my slides okay and hear me all right?
Yes.
All right, awesome. Thanks so much to MSG for the invitation to speak today. This, like Jim, this is also my first MSG meeting, so I'm thrilled to be here and present this data on behalf of the task force, the EAN-PNS task force. Here are some of my disclosures. So the objective of the discussion today is really just to highlight the importance in the content of the new guideline, and I'll try to do this by using the 2010 guideline as a reference point. Included in the new guideline are new diagnostic and treatment recommendations. So there's quite a bit to discuss here. So certainly I can't get through it all, but some of the highlights I'll try to hit. Before getting into the details of the guideline, it's important to acknowledge the task force that put these guidelines together. Chair of the guideline was Peter Vandenberg. The committee consisted of 17 disease experts, 1 patient representative, and 2 methodologists. This was a worldwide endeavor. 12 countries were represented. Before the pandemic in 2018 and 2019, the committee met at PNS meetings. After the pandemic and during the pandemic in 2020 and 2021, the guideline was completed through a series of Zoom meetings. And the funding for the guideline was generously provided by the EAN-PNS GBS Foundation and McCain Charity UK. So before talking about the content of the guideline, why is this guideline so important? Well, we know one reason the guideline is important because the misdiagnosed CIDP diagnosis can be challenging. There's no single diagnostic biomarker, as Dr. Gable was discussing, really to lean upon to make this diagnosis. And so putting together the diagnosis requires us to put together all these different bits of data and hope we land on the right spot. And we know that kind of worldwide, we're not so good at this. Several independent groups have looked at the frequency of misdiagnosis of CIDP in both academic and community centers in the US and abroad, and found that the frequency of misdiagnosis is very high. In the US, over half of patients that carry diagnosis of CADP have been found to have something else. So how can we put together all these individual bits of data together to more accurately make a CADP diagnosis? Well, one way is to reference a guideline. Since Dr. Biederdick gave a name to this disease and presented the first diagnostic criteria in the 1970s, there's been over 15 sets of CADP diagnostic guidelines proposed. The sheer number of these guidelines really highlights the difficulty with defining this disorder that doesn't have a reliable biomarker. Now, over the last decade, the most widely used guideline has been the EFNS-PNS guideline, which was published in 2010. And this guideline has been shown to have the most favorable blend of sensitivity and specificity and is commonly used in clinical trials. But there's a lot new since 2010. And so this guideline has been revised. It now goes under the name of the EAN-PNS guideline. And the new guideline, as we'll discuss, has several updates in clinical definitions, the roles of imaging and antibodies, as well as some treatment recommendations. The guideline was published within the last few months in the European Journal of Neurology and also the Journal of the Peripheral Nerve Society. So a bit about the methodology of this guideline. How was it constructed? Well, the methodology followed a framework provided by the EAN. 12 research questions were constructed in the PICO format, 7 questions for diagnosis and 5 questions for treatment. Each PICO went under an intense literature search. The task force assessed each PICO using a decision-making framework called GRADE, and the recommendation for or against the test or intervention was made based on the strength of the data. For many of the PICOs, definitive data, of course, does not exist. And so when no data or only low-quality data was available, but consensus could be reached, the task force offered advice as good practice points. So using these definitions, the task force was able to define grade level recommendations to all the treatment PICOs except for pain, and applying grade recommendations to diagnostic PICOs was more challenging because of the quality of the data. So all the diagnostic PICOs led to good practice points except for electrodiagnostic, which reached a grade level recommendation. So let's look at the guidelines now, kind of with a high level overview. You might recall in 2010 guideline, there were 3 diagnostic categories. Those were definite, probable, or possible, and each required a minimum of clinical features and predefined electrophysiologic abnormalities. In cases where the electrophysiologic abnormalities were less convincing, the diagnostic category could be upgraded by collection of some supportive data. The new guideline recognizes that in the absence of a diagnostic biomarker, it's really virtually impossible to be completely sure of a CADP diagnosis. And so this term definite was removed. It was also appreciated that the differences in the specificity and the sensitivity in the probable and possible CADP were minimal, and this probably unnecessarily complicates the guideline. So the probable classification was also removed. From a supportive standpoint, ultrasound was added. We'll talk a little bit more about that later. And sensory conductions removed from the supportive criteria because they've now been folded into the main electrodiagnostic criteria. So for the new guideline, you've got 2 categories instead of 3, and those categories are CADP and possible CADP. The fundamental requirement of both categories remains fulfillment of a clinical definition of CADP. Electrodiagnosis also remains a critical part of diagnosis. Supportive criteria still allows you to go from CADP, possible CADP, to CADP if more than 2 supportive criteria are met. So getting into the clinical criteria a bit more. What are some of the differences between 2010? So in CADP, the previous classification in CADP was either typical CADP or atypical CADP, depending on certain clinical features. Because these atypical patients have now well-characterized clinical and electrophysiologic features, the task force felt it important to use a less dismissive term than atypical when referring to them. So instead of using atypical, the new guideline simply calls them CADP variants. And these variants go by the name of multifocal CADP, distal CADP, motor CADP, and sensory CADP. And each variant has an improved definition that's within the guideline. From an electrodiagnostic standpoint, there's a lot to unpack here. Like the clinical criteria, prior electrodiagnostic class, there were 3 electrodiagnostic classifications in the 2010 criteria. And these were labeled as definite, probable, and possible. These, even more so than the clinical definition, proved problematic. And certainly not everything that's demyelinating is CADP. And so the new criteria slims the categories again from 3 to 2 and replaces the terms definite, probable, and possible with strongly or weakly supportive of demyelination. The predefined severity and the number of demyelinating changes are similar to prior guidelines, but there are some important differences. And most of the important differences come from the recognition that one overarching electrophysiologic definition may not be the best way to capture some of the CADP variants. So let's go through some of the variances. Some of these changes are worth highlighting. So starting with typical CADP requires 2 predefined abnormalities to make a diagnosis and 1 for a possible diagnosis. But the situation that comes up not infrequently is, what if a patient fills a typical clinical definition of CADP, but not the electrophysiologic criteria? There may be a number of reasons for this. For example, if one has very severe disease or very unexcitable nerves or profound axon loss. In the old criteria, you could not make a diagnosis of CADP under these conditions. The new criteria recognizes this limitation and allows for a possible typical diagnosis to be made even without electrophysiologic data, as long as there is objective improvement with immunotherapy and at least 1 other supportive criteria. In the case of distal CADP, the task force recognizes that this is one of the most common misdiagnoses of CADP. This is frequently misdiagnosed as CADP, and one of the reasons that misdiagnosis in distal CADP happen is because of erroneous interpretation of mild or moderate slowing and lowered limb nerves that's not necessarily from demyelination. And so for this reason, motor nerve conduction criteria fulfillment is now required in at least 2 upper limb nerves when dealing with distal CADP. When criteria are fulfilled in lower limb nerves, but not in upper limb nerves, the maximum diagnostic certainty for distal CADP is possible. In multifocal CADP, abnormalities are required in 2 nerves and 1 or more limbs. If only 1 nerve is affected, then a possible diagnosis is made. For motor CADP, a patient must fulfill criteria in at least 2 nerves, and the sensory conduction, of course, must be absent or must be normal. There's one caveat to motor CADP, and that's what to do with somebody that's clinically motor but has sensory conduction abnormalities. These patients are now classified as motor predominant CADP. For sensory CADP, one must fulfill the sensory conduction criteria, which is now detailed in the guideline, and the motor responses must be normal. Sensory CADP is another variant that's quite difficult to diagnose, and even some of the sensory criteria, such as cerebral sparing, aren't necessarily indicative of demyelination. And so for this reason, the maximum diagnostic certainty for sensory CADP is possible. In addition, in some patients with like motor CADP, if they have motor conduction abnormalities but a clinical syndrome, they are classified as sensory predominant as CADP. So how about some of the supportive criteria? So in the prior guidelines, the things that were used to support a diagnosis of CADP are things like response to treatment, MRI findings, CSF, sensory conduction changes, and nerve biopsy. Since 2010, there's been, of course, a lot of new data that's emerged. It's important to have a couple of caveats or words of caution about the supportive criteria, and that these criteria are never used in order to diagnose CADP in isolation. And when we see them, they may make a diagnosis of CADP more likely, but they don't replace the need for really sound clinical and electrophysiologic findings. So with that disclaimer, kind of walking through these different bits of data that are considered supportive. One is attested treatment. So if a patient benefits after treatment, that's often considered supportive of a CADP diagnosis. And while this is important, and it's certainly good to see patients do better after treatment, the potential pitfalls of this practice are many, including the fact that immunomodulator treatments are not specific for CADP. So for this reason, the task force considered response to treatment as supportive of a CADP diagnosis, but with one very important caveat, and that is that the improvement must be objective. The task force stressed the use of objective measures of improvement when determining treatment's response, and they encouraged using at least one disability metric and one impairment metric in order to say somebody has objectively improved. Within the guideline, there are specific recommendations when using the scales like INCAT or iRODS or grip strength, to know if the changes they're seeing are meaningful or not. So please go ahead and check those out. For imaging, what we're talking about is MRI and ultrasound. And over the last 10 years, there's been many publications in ultrasound and CADP, including 12 cohort studies that have been used for this, analyzed for this guideline. And on the basis of these, and new for the 2021 guideline, ultrasound is now recommended as a supportive criteria for patients with possible CADP. The diagnosis of CADP may be more likely if there's nerve enlargement at least 2 sites of proximal nerve segments or the brachial plexus. For MRI, although CADP may be more likely if there is nerve root or enlargement or enhancement, because of low rater inter-rater reliability, lack of objective cutoffs, and the cost and availability of MRI in some settings, the task force recommended against using MRI in most scenarios. In scenarios in which ultrasound is unavailable or inconclusive and the diagnosis is still of CADP is still only possible, then MRI may have some applicability. Regarding CSF, it's recommended that CSF not be needed, not be obtained if the diagnostic criteria are already met, as this would add little to the diagnosis. CSF analysis may be helpful in certain situations. An elevated protein may be helpful to increase the diagnostic confidence of patients with a possible diagnosis. An assessment of the white cell count may be valuable in certain CIDP mimics are under consideration, including malignancy or infection. Task force also provides some advice on when to use caution when assessing or interpreting CSF values, such as those older individuals or patients with diabetes, and the observation that well-defined cutoff values for what's considered a normal CSF and what's an abnormal CSF are quite variable from lab to lab. The task force did not recommend nerve biopsy as a routine diagnostic tool, but does recognize the value of nerve biopsy in certain situations. Nerve biopsy may be helpful when a CADP diagnosis is suspected but cannot be confirmed with the available clinical laboratory imaging or electrodiagnostic studies, or when certain mimics, including amyloid or vasculitis, are the differential. Specific histopathologic features that might be appreciated in CADP nerve are discussed within the guideline. One of the very nice features of the new guideline is this flowchart that breaks down the electrophysiologic and supportive data specific to each clinical variant. As discussed earlier, there are just two diagnostic categories that are principally defined by the clinical and electrical features, but one can move up in the diagnostic category if two supportive criteria are present. And you'll probably make note of two other features in this chart, and that's the situation of the nodal, internodal, perinodal antibodies, and also when to consider mimics. So let's talk about those a little bit more. Since 2010, antibodies against nodal and perinodal proteins have been discovered in a small set of patients with CIDP. The antibodies go by the names of neurofascin 155, neurofascin 140, and contactin 1. It's beyond the scope of this talk to really get into the details of those antibodies, but the task force proposed to name these conditions autoimmune nodopathies, not to regard them as CIDP variants. The reason for this was this decision because of the distinct clinical features of those patients that harbor those antibodies, the absence of inflammation and macrophage-mediated demyelination, and the poor response to CIDP first-line treatments, in particular IVIG. The task force made a recommendation to consider testing for nodal perinodal antibodies in patients that fulfill CIDP criteria, and an even stronger recommendation for testing under certain conditions. And these included patients that are resistant to standard therapy, have acute or subacute aggressive onset, tremor, ataxia, respiratory failure, or have a nephrotic syndrome. One important part of the 2010 criteria was exclusion of disorders that could look like CIDP. A diagnosis of CIDP cannot be made if there's a better explanation for that patient's neuropathy. And over the last 10 years, the difficulties in identifying this disorder are still, without the diagnostic biomarker, have been realized. And so it's now understood that misdiagnosis is especially problematic for the CIDP variants. Typical CIDP is less problematic, but the variants can often give us trouble. So for the 2021 guideline, exploring mimics is again reinforced, and the importance of excluding CIDP mimics is enforced, but the guideline tries to be more helpful in this regard. So the new guideline recognizes that the differential diagnosis for typical CIDP in each of the variants is not the same. Within the guideline are now lists of CIDP mimics specific to each variant that can be considered. It's a very helpful list of things to think about depending on unique clinical features. The guideline also now includes this flowchart of red flags, which is also broken down by each CIDP variant. Within the flowchart, you can find specific clinical and laboratory features that might cast doubt upon a CIDP diagnosis. Again, another excellent resource that can raise an alert that maybe perhaps what you're dealing with is not CIDP. All right, so moving on to the treatment guidelines. And then again, there's a lot in here that I can't go over all, but sort of a high level overview of how what's in the treatment guideline. Because in 2010, the guideline gives some advice on evidence-based treatment recommendations and some good practice points. The 2021 guideline in the 2021 guideline, the task force considered new data that's emerged since 2010. It also tries to make the treatment recommendations a bit more helpful. So treatment recommendations begin after a CIDP diagnosis is made. Patients fulfilling the criteria are advised to start one of the first-line therapies, either IVIG, corticosteroids, or plasma exchange, if there's some level of disability and if there's a reason to believe that the patient's disease is active. The guideline provides some specific evidence-based dosing recommendations for induction therapy based upon the existing clinical trial data. Although there's no consensus on if corticosteroids or IVIG is preferred, the task force recommended using IVIG in patients with motor CIDP, as those patients may deteriorate after corticosteroid exposure. If there's objective benefit following one of the first-line therapies, then the guideline provides recommendations for maintenance therapy with either corticosteroids or IVIG. The guideline now also recommendations consider of subcutaneous IG for maintenance therapy. One proven effective maintenance dosing of IVIG is 1 gram per kilogram every 3 weeks, and a proven effective subcutaneous dosing is 0.2 or 0.4 grams per kilogram weekly. The guideline now also recognizes that there may be a gray area of treatment where some patients have a complete response and others have a partial response. If only a partial response is appreciated, then an escalation of treatment can be considered. In this event, the dose or frequency of treatment could be increased or combined treatment could be attempted. If there is a complete response, it's important to assess for ongoing disease activity by periodically reducing the dose or frequency of immunotherapy. For newly diagnosed patients, this could occur every 6 to 12 months. For patients on long-term therapy with prior dose optimization attempts, further dose optimization trials may occur less frequently. If during the weaning process, no objective deterioration is documented, then the disease may be in remission, and maintenance therapy may be suspended, as is in the case of about a third of patients with CIDP. If objective worsening does occur, then therapy should be resumed. In that event, consideration of adding an immunosuppressant agent to IVIG or corticosteroids as a way of lowering dependency is reasonable, although the quality of evidence for all steroid IVIG sparing medications for this purpose is quite low. Now, what happens if there is no objective improvement? If there's no objective improvement, what do you do then? Well, the compulsion is typically to increase the treatment in patients that do not respond to the first-line treatment. But it's important to keep in mind that the most likely reason that patients don't respond to the first-line treatment isn't that the drug's not working, but rather the diagnosis is wrong. So if a patient does not respond to first-line treatment, the task force strongly recommends reconsidering the diagnosis and, if possible, referring to a CIDP specialized center before escalating therapy. If the diagnosis is reconfirmed, then it'd be appropriate to try another effective therapy. So if IVIG was started first, next try corticosteroids. Steroids were started first, the next option would be IVIG, unless there's a contraindication not to do that. If that does not work, then it's back to the drawing board before considering further treatment. If the diagnosis is still likely, then a third proven effective therapy would be recommended. Once again, if there's no effective improvement, then we think about the diagnosis. For that very rare patient that has failed all first-line treatments and no other diagnosis is likely, then consideration of a different immunosuppressant for induction can be entertained. But the quality of evidence for all of these alternative options is quite low. And of course, for each step along the way, if there is objective treatment, then the rules for maintenance therapy and assessing for partial and complete response apply. So that's the guideline updated for 2021. Certainly there's a lot more in there that I don't have the chance to cover, and I'm not able to review everything. One important message that the task force does want to convey is to kind of bring this guideline from clinical trials into routine clinical practice, routine clinical care. So please take this guideline to your colleagues and your fellows, and your residents and your students. Please help disseminate this information. We think that while no diagnostic approach is perfect, we do believe that adherence to these guidelines may lead to a faster diagnosis, minimize misdiagnosis, and streamline the treatment approach. I want to thank everybody that was part of the task force on whose behalf I present this data, in particular Professor Vandenberg. And I also want to give a plug to the Peripheral Nerve Society meeting that will take place in 2022 in Miami and the year after in Copenhagen. So thanks again to everybody and the organizers of the MSG meeting. Be happy to take a few questions if there's any comments.
Thank you, Jeff. That was an excellent summary of a very, very complex work and time-consuming work from your part and your team's part. Jim, do you want to come online and ask your question directly?
Yes, I do. Hi, Jeff.
Hey, Jim.
sorry, I can't put myself on the video, but anyway, I'll talk to you. I think that was a very nice talk, and I think your committee clearly did a very nice job and was very thoughtful. I think that traditional CIDP gets very well diagnosed by community neurologists. So sitting in an academic tertiary referral center, I see atypical CIDP way more than I see typical CIDP. And so oftentimes the electrophysiology doesn't show much demyelination. And I personally am highly reliant on proximal MRIs, on CSF, and on targeted fascicular nerve biopsies to make diagnoses that wouldn't meet your criteria. And one example of this is the CISP and the CISP plus. Why did your committee? I mean, Vandenberg and I had a conversation about it. He said there were members on your committee who felt that CISP was purely a polyradiculopathy, therefore wasn't CIDP. That still doesn't make much sense to me.
Yeah, so you're exactly right. And I think we all agree that the atypical, or what used to be called the atypical variants, are the ones that are really diagnostically challenging. Typical CIDP is fairly straightforward, but we know from a lot of the published work that when misdiagnosis occurs, it's usually those atypical variants. So the committee, the task force, really stressed the importance of better defining these variants, both in their clinical terms and their electrophysiology. The committee also wanted to be more inclusive of a CIDP diagnosis to capture more of those patients. So that's the reason that now you can diagnose CIDP without meeting electrophysiologic criteria for typical CIDP in certain situations, and why now sensory CIDP includes some sensory conduction abnormalities without requiring motor conductions. So there was an attempt to make it more inclusive. Now the CISP did kind of get lost with all of that, and there was a lot of discussion, and it wasn't a there was a lot of discussion on where exactly to put that, and ultimately, because of the rarity of it, it was considered as a separate condition. Is there a spectrum of CIS plus CIDP? Probably. And so I don't know if you have data on how many of those CIS plus patients might be captured under the new criteria with the sensory conduction abnormalities, but hopefully some of them then would be.
Well, so in our series, none of them would meet your criteria. None of them had enough demyelinating features on the nerve conductions to be made. I think that is my big problem, is that I've always had this problem, and I think you've tried to address it, but I think the criteria put too much emphasis on nerve conduction studies. And that's again, because I'm sitting in a place where I'm essentially seeing atypical cases. But, I think your original work is incredibly important to say that too much emphasis is put on by the community neurologist on mild nerve conduction abnormalities. But I think the opposite is true. In the difficult cases that really are CIDP, or that are proximal predominant, that don't have a lot of demyelinating features on traditional nerve conduction studies, they can still be CIDP. And sure, you can go about this kind of backwards way, but the problem we have now is that insurance companies don't want to pay for IVIG. And so taking CISP and some of these other things out of CIDP, you can say, well, if you can show objective evidence of improvement with immunotherapy, then it's CIDP. But if I can't give them immunotherapy because the insurance companies won't pay for the immunotherapy because they say it doesn't meet the criteria for CIDP, that's a problem. And so I don't really care if CISP is part of CIDP or not part of CIDP from that point of view, but if insurance companies tell me I can't treat it because now it's no longer part of CIDP, then I care a lot.
Yeah, it is an issue. I wish I had a better explanation for you right now. But.
So, Jim and Jeff, I mean, according to the criteria, all CIS patient falls under possible CIDP, because for possible CIDP, you don't need nerve conduction study. You need response to treatment and supportive criteria, such as abnormal MRI, abnormal protein, etc. So you actually are putting a lot of the CIS as possible CIDP.
Unless but again, the response to treatment gets, if you're not allowed to treat them in the first place, that's a bit of a problem. Yeah, and I'm not trying to throw this on you, Jeff. I mean, I don't hold you personally accountable for all of this. I had a lot of conversations with Peter Vandenberg about it. But
yeah, it's a valid issue without a clear answer right now. But yeah, a lot of those patients would still but you could still call a lot of those patients CIDP.
Yeah, well, I think they are CIDP personally. I mean, I think it's inflammatory demyelination. I mean, to me, the paranodopathies are kind of lookalikes, but probably not CIDP. But the cysts, in my view, are just, why you get this restricted focal involvement of the sensory root in some patients and not in others, I don't know. But, pathologically, it's inflammatory demyelination.
Yeah, and I think we have Gordon and Tony Amaro.
Yeah, I'll shut up. Sorry for taking too much time.
No worries.
Jeff, I'll let you end with another comment if you want. Somebody, because we're running out of time, but somebody mentioned that maybe we should screen for genetic neuropathies. That's Dr. Payam Soltazande, especially for those with refractory CIDP. Do you want to comment?
So within that's a great point. And within the guideline, within one of those flow sheets that I showed, the red flags one, it's sort of things to consider in certain clinical scenarios. And some of those scenarios include things like, is there a family history? Is there a absence of a response to treatment? And some other features, depending on what the variant is. And genetics is screening for genetics in certain clinical scenarios is important. So it's not something that you have to do in everybody or you should do in everybody, but there are some red flags that would certainly make that an important thing to do.
Thank you, Jeff. This is a very complex topic, so thank you for presenting this so nicely. And you guys can chat with Jeff if you want offline and text him. But we're going to transition now to Gita Rambari, who's going to talk to us about outcome measures in inflammatory neuropathy. So Gita, please go ahead.
Thank you. I'll just try and share, and hopefully that will come up for you as well. How's that looking? Can you see this? How's that? Yeah, is that better? Perfect. Okay, great. Thank you very much for inviting me to speak on outcome measures. I feel like I'm a bit of a dabbler in outcome measures. There's certainly groups who are doing some excellent work on this around the world, and that will be mentioned. But certainly there's some specific work we've been doing at UCL and at Queen Square that I'll introduce you to now. But just to go back, I think sometimes it's very helpful to go back to basics and see what we're actually setting out to do here. So measurement in its purest form and how we're doing it when we're looking at health outcomes is assigning numbers to categories of observation. And actually, it's always a good reminder to think about the properties of the numbers that we're looking at. So we have continuous data. It starts at 0, it's linear. You get continuous outputs, for example, with blood pressure or weight or height. And then we also have interval data as well. So this is where there are categories, but we know the size of each category. In this example, this is age bands, and we know that each of those blocks is 10 years. And then probably what we're most commonly encounter with PROMs, patient-reported outcome measures, and functional outcome measure disability scores is ordinal data. So this is hierarchical. We can see whether there's somebody's less affected, for example, or more affected, but we don't necessarily know the size of those increments and those bars that we see on this symptom scale that I've just put there. And then much more simply, again, is nominal data. So this is just where we group according to category. There's no hierarchy. So this could be ethnic background or sex. So when we're trying to measure, we use an instrument, we use a tool, and that tool will be trying to focus on the construct. So the construct is actually the theory or the thing that we're interested in. And then, so what we want to do with that tool, the tool might have one or a number of items, and we want to see how that responds. So when we're wanting to make a change to a construct, we'll measure using the tool, we'll look at the change in the items, the item response, and then we might be able to make assumptions about whether or not what we've done, an intervention, has caused a change in the construct. Or we might be monitoring, for example, with natural history, and if we see changes in the items change, then that infers that there's change over time with the construct. So what's one thing that we've been using quite a lot in some of the work that I've been doing with colleagues is actually using frameworks to help to organize and how we actually look at measurement and what level we measure at. And so I'm a therapist by background, I'm a physiotherapist, and what's quite key in a lot of our training and when we're assessing people is something called the World Health Organization International Classification of Functioning, Disability and Health, known as the ICF. So when we're assessing a construct, the framework of the ICF breaks it down into body structures and functions, and that's what we might be assessing. Also activities and participations, which can be affected by the two previous areas. And then also there's an element of environmental factors as well. And all of these contribute to how a person functions and their health outcomes. So how might we look at this with outcome measurement? Well, of course, we've got to think about the data sources, and the sources of data will vary as well. So we heard a lovely talk earlier about biomarkers, so physiological biomarkers. We also do a lot of performance measures. We might time particular tasks, clinician observed rating measures, and patient-reported outcome measures. And these are just some of examples of different things at those levels. So with structure, it might be muscle volume, joint range, function, it could be muscle strength, for example. Activities, it could be ability to climb stairs, and participation is people's ability to go to work or go to school or participate in family life. So just looking now at some of those in a little bit more detail. So I think probably, a lot of us, we're biomedically trained. That's the sort of our professional background. So we're often very comfortable with physiological biomarkers, whether it's tissue, it's neurofilament light chain or serum CK. And also, as has already been mentioned in a couple of talks, the great work that's being done at the moment in imaging, which gives us some very important structural information. There can also be performance measures, so with some dynamometry for muscle strength or myometry, which is used a lot in some of our trials. It could also be performance such as cardiopulmonary exercise testing, looking at oxygen uptake and aerobic capacity. And also one thing that my team do a lot of is gait analysis. And so just to look in a bit more detail, a specific performance measure that we've been using quite a lot. So this is a maximal exercise test for somebody with Charcot-Marie-Tooth disease using an incremental bite protocol. And this is the VO2 output. So you can see where the peak occurs. And this is in the same study where we're doing it with somebody with IBM. So this is this continuous data that I was talking about earlier. It's linear. It's easy to follow when you've got the you can actually got a degree of accuracy with it with a high-tech methods of collecting it like this. And actually what we can then do with it is that we can make comparisons, and we've just literally had this paper was accepted this week in open access, where we can compare the CPET testing for people with CMT and IBM using parametric statistics like a t-test, for example. That's what we used, and that can be used with this sort of data with the right assumptions. Also, you can use it to look at outcomes. So we did an exercise intervention, and we published this a couple of years ago, where we looked at and used the CPET testing to look at outcome, performance outcome after training. And also in that study, we used a measure of activity, physical activity, as a performance measure. So it's not just body structure and function for performance. Performance measures are used a lot to look at an activity level function. So this was using an accelerometer that was worn on the arm, and we were able to look at whether or not there were changes in people's 7-day physical activity, for example. So now if we look at other types of measures, so the clinician observed rating measures, patient reported outcome measures. So this is where we go into the domain of rating scales. They're very commonly used to measure health outcomes. And, as we saw earlier, they can be used quite a lot as primary or secondary outcomes in treatment trials. But the issue is that historically, they haven't always been that well constructed, and they can be at quite high risk of type 1 or type 2 errors due to the issues with sensitivity and responsiveness. Reliability and validity, there are lots of papers out there that look at this, but the problem that we have with these ordinal scales is that, as I mentioned earlier, the assumption is that all the points in the scales are equally spaced when they're actually not. So they don't look like a ruler like this. they look a little bit more like this, where each of the categories could be different sizes. We don't really know. Some of them could be clustered. It could be very difficult to tell one category apart from another. So this, so looking now in a little bit more detail, so single item scales are used quite a lot. So here, this is the Ashworth scale that's used a lot for spasticity. And we tend to we can identify a construct like spasticity. It's in our clinical experience, so we identify with it. But the problem is when it's only a single construct, there's lots of complexity surrounding something like spasticity. And so you don't tend to see what's contributing to that. They often have poor reliability, validity, and responsiveness. Whereas when there are multiple item scales, and the example here is the IBM FRS, which is well known in the MSG. So here they can account for the complexities of constructs. So this is physical functioning. And so it can be looked at with lots of tasks and lots of levels. That actually means that there's improved validity, reliability, and responsiveness. But it's still an ordinal scale, so that can be problematic. So a couple of years ago, we published this work, and this was a collaborative work across the MSG, where we refined the IBM FRS using rash analysis. So I'll explain what that is in a little bit more detail and take you through the analysis that we did. But we collected single observations from 132 patients across 4 institutions of the MSG. And these were the demographics of the people that we collected the data from. And what rash analysis gives you, there's different software. There's one called WinSteps, there's one called RUM, which is the one I use, RUM 2030. And so when you actually put this through the rash analysis, there's some quite useful stuff that you can look at. So here, this graph, this is a threshold item map, so person item threshold map. So what it shows you on the bottom in the blue, this is along that ruler that we were looking at earlier. This is where all the different items sit in terms of difficulty. And then in the pink here, these are the different observations, these are the patients, and where they spread out across that ruler. So it's very helpful to see, well, do all the items cover all of the ability levels required for the patient group that you're looking at? And it sort of does, but there's odd gaps here, but it sort of did. So that wasn't so much of an issue. You can also look at the individual items. So there's 10 items in the IBM FRS. And this is the swallowing item. And what we found is we look at this little statistic here called the fit residual. That's very high. You can also plot, these are called class intervals, which look at the spread of abilities in the patient group, and to see whether or not that actually corresponds with a plot of the rash model. And it doesn't. So what actually we found was that the swallowing was an undiscriminating item, so it didn't fit the model. It didn't seem to fit what was happening with the rest of the items in the main scale. You can also look for things like item dependency. So are there items that are highly correlated? So we found here that in pink, these are the ones that are highly correlated. So there are, can somebody switch their microphone off? Thank you. Thank you. So here we can see that there is highly correlated items. So in these cases, this one is the items cutting food and fine motor skills. You can see why they may be highly correlated. And then this one is walking and stair climbing. So if there's dependency, then a decision can be made whether or not you only need one of those items, or actually there's a clinical reason for keeping both. And then the other thing that rash will give you is so when we look at all of the categories with each item, so that hierarchical scoring, is it hierarchical, or actually is there some issue? Is there some overlap between the categories? And there were for some of them. So we were able to refine these. We were able to make some adjustments to the scale. If anybody wants to know the details, they can have a look at the paper. But this is basically what we came out with to help with that problem of not knowing the size of those ordinal categories. So this is an interval transform scale, basically. So you score, we actually drop the swallowing item, but still have it on the assessment sheet because it's important to look at, but actually numerically including with the other items didn't quite work. So, but what we now know is on this score of 0 to 33, the size of all of the increments between each category. So now we've actually made a ruler. So we now have an interval scale, which means we can use parametric statistics. It can be a little bit more powerful in terms of analysis and hopefully help that issue with type 2 error. So moving to the next issue, The IBM-FRS was developed by clinicians, and as many scales have been. And so are these outcome measures patient-centered. So the clinician, we might be saying, I know what's important, what I need to see and what I need to measure for this patient. But then the patients may say, well, I know what it's like to live with this disease, and I know that what change would make a difference to my life if you were to give me a drug or help me with a training protocol. So there are lots of recommendations now. And as I said, there are some institutions doing this sort of work extremely well. So in Rochester, there's groups in the Netherlands, and certainly our colleagues in Newcastle. And the steps are developing from start with understanding the patient experience. So doing qualitative work. So take interviews, pulling out themes, seeing what's important to people. And then there can be a process of agreeing and refining and reducing those items. And that's where the expert opinion can come in terms of particular relevance to the construct that is specific to the work that needs to be done. Then the next step would be collecting data on those single observations like we did with the IBM-FRS. And then through that analysis, this is where statistical work such as principal component analysis and rash analysis can be used to look for this redundancy, to look at any item clustering, to see how those individual items are functioning. And then when you have a refined scale, the next step would then be to refine it and then retest it, and then look for acceptability, validity, and then responsiveness over time. And so this is Victoria Selby, who's a PhD student at Great Ormond Street and the Institute of Child Health with Professor Francesca Montoni. So she's been working with us at Queen Square on developing a pediatric and adult home-based tool for people with myasthenic syndromes. So a tool that people can use themselves to monitor the fluctuation in their symptoms. So she started with when generating the items, she started with qualitative interviews. So she did semi-structured interviews with 10 adults and 7 children and their parents, and then did a thematic analysis, which is a Braun and Clark analysis, which is quite commonly used in qualitative research. She then mapped the themes that were coming through onto the ICF framework. And this is where the sub-themes that she found, that there were physiological difficulties, which was the focus of what we were looking at, which related to the body structure, function and impairment. And I'll show you more detail of that in a moment. But interestingly, other things came through to do with psychological impairment and lifestyle management, which I think we will look at when this work is complete, as we were focusing on physical functioning. But there's some very useful, very interesting information coming through, as is often the case with qualitative work, that it goes into a lot of detail, maybe where you don't anticipate. So this is quite a busy table, and apologies for that. But what she did with the information that came out of the interviews is that she identified the functional aspect that we then wanted to try and quantify with measurement. So here, the fatigability of the eyes, fatigability of speech, muscle strength and fatigability, fine motor control, whole body functional weakness and fatigue, and neck weakness. And so what she then did was a scoping review of outcome measures. She identified different measures, some that are used in myasthenic syndrome, some that are just used in neurological populations for physical function that we're very familiar with, such as time walks. And she matched those to the domains those functional domains that we'd identified. And then we came up with a list of items that then we were going to test. And so they were tested in 15 children and 40 adults with myasthenic syndromes. And so we used what's the rash analysis experts call an item banking process, where you can pull items from different places and put them together through the rash analysis to sort of construct your own, as it were, construct your own outcome measure. And we whittled it down with a principal component analysis, and we did the rash analysis. And we were left with 23 items that performed well. And the 23 items then great. But when you're thinking about a home-based measure that you want patients to do, we knew that that was not going to be feasible. So the next stage was the clinical sense checking with expert clinicians. So again, this is bringing in the clinician perspective as well, which is very important. So what we did then was that we worked out, well, what would be feasible at home, what wouldn't. And actually then this is the scale that she's now tested out. She's done a feasibility test at home, and she's just finishing off this development paper for publication, hopefully very soon. So here they're doing the repeated sit stand, they're doing the box and block test. If we give them the equipment, tearing paper, and then there's 4 questions here. So this is what people can do to monitor and self-manage and get a feel for when they might be running into trouble with their symptoms. So the next element is core outcome sets. So when we have, a lot of trials use many different outcome measures, as we've found in some of our scoping reviews. And of course, that can be a problematic when it comes to meta-analysis, as we often see in Cochrane reviews and other systematic reviews. So there's initiatives such as COSMIN and consensus-based standards for selection of health instruments, and COMET, and they have particular guidance that they give in order to develop core outcome sets for particular conditions. So we've just had this accepted for publication. This is some collaborative work I've done with some colleagues around the UK and in Scotland, Wales, and England. And so we followed the COSMIN guidance. So the step 1 is the conceptual considerations. And again, there's a big patient engagement element with this. So we had an initial workshop with people living with the condition, carers, and charity representatives who got feedback from their members. Just what are the issues? And then we had a follow-up workshop where we defined the constructs that they thought would be important, that needed to be measured in a core outcome set. We then went out to find the existing outcome measures that might already fit that bill. So we did a scoping review of systematic reviews. And if we didn't find anything that fit exactly what they wanted, we then decided that we would do another search using those construct names as search terms. Once we'd found candidate measures, we then did a matching and assessing process. First of all, we as the academic panel, we looked at the psychometrics and did a quality review. When we did that, we took it back to our PPI group, our patient public involvement group, and the charities to introduce them, give them time to have a look, have a think, and then we had a final consensus meeting where we agreed it. So what they told us was important. Was very interesting, and actually it wasn't what we were anticipating. Again, probably we're looking at a biased clinician lens. So the things that were important to them was specific symptoms such as preserving function, staying well, improved mood, and positive effects. But also day-to-day activities such as social engagement, taking control and making choices, and benefits to carers as people were more physically active. And so what with the constructs, with the different elements that we broke down, particularly the physical functioning, independence, etc., we didn't find anything in the scoping review. So we had to then go out and do another search. And we found the OXPAC, which is the Oxford Physical Activity, it's the participation and activity questionnaire, which covered the white tick. So that covered those constructs. And then where there were gaps, we found the sources of self-efficacy for physical activity. But also, just to let you know, there's still some very good outcome measures there. You don't have to necessarily design your own. So there's registries, Treat NMD. In the UK, we have OpenTact, which the Newcastle team, that they look after this, and there's the North Star, different scales on there as well. So just to sum up, when we're thinking about outcome measures, we certainly have to think about when we're using them either clinically or in research about the precision of the source and the type of data that we're looking at. And certainly considering the level we wish to measure, what are we expecting to change, and thinking about when we designate primary outcomes. There are certainly tools out there for refining existing measures, as we did with the IBM-FRS, and the models are there for developing new prompts. And as I said, I think the team at Rochester are absolute masters at doing this. with a lot of the health indices that we're seeing coming out in neuromuscular diseases. And of course, one thing that COVID has taught us is actually thinking about remote measurement, which is easy enough with PROMs because you can give those out as online surveys. But what about some of the functional measures? And so there's some work going on with the Inherited Neuropathy Consortium to look at 2 remote measures. And Katie Eichinger from Rochester is leading some work. We're looking at the CMT functional outcome measure, how we might do that remotely. And we're collecting data on that at the moment. And also, if we're thinking about, in a big group like this, where we might be conducting work that we want to bring together in a meta-analysis, should we be looking at these core outcome sets? And certainly Bhaskar Roy and Simone Thomas we're looking at this as a group as well to see if we can do that for IBM. And so this is the research group and our research nurses who make a lot of this work possible. So thank you very much for your attention.
Thank you, Gitta. Great presentation. It's always important to focus on, patient outcome and what is important to the patient rather than what the clinician thinks is important. Do we have any questions for Gitta before we take a break? Okay, Gitta, thank you so much again. We're gonna take a break. The break is sponsored by PTC Pharmaceutics. They're not gonna take question, but if you can join the GenTech mingle later to ask any specific questions.
All right, we're back from the break, and thank you, Shafiq, for moderating the last segment. So I'm really glad today to present our next MSG Fellowship presentation. And most of you were on yesterday. For those of you who are not, just remind you that the MSG actually funds and supports a fellowship program in collaboration with the American Brain Foundation and the AAN. So the MSG contributes 2/3 of the fellows' support, and the ABF supports 1/3. It's a 2-year clinical translational research fellowship. It's primarily aimed at clinicians that are doing research, but it doesn't necessarily have to be, but all of them so far have been in that realm. They can be US, but they can also be international as well, but we haven't had an international fellow yet. Applications open in July, and they go to the ABF, and we select them. They're due October 1st, so they were due yesterday for the fellows starting in July, and then they get selected in December with notification in January. So yesterday, we had Paloma Gonzalez Perez, who was in her 2nd year of fellowship. She's at Mass General. Today, I am very, very thrilled to be able to present Renata Knox. Dr. Knox completed her MD and PhD at UCSF after she'd been an undergrad at Harvard. At UCSF, her mentor was Donna Ferriero, really famous pediatric neurologist at UCSF, which many of you are familiar with. And in that lab, she studied cell signaling and neonatal brain injury. She went on to New York Presby and Weill Cornell to do her pediatric neurology residency. And during that time, she became very interested in advances in neuromuscular medicine. And she decided to pursue a career in neuromuscular disease. She did a neuromuscular fellowship at Nationwide Children's Hospital and Ohio State. And then she joined Dr. Scott Harper's lab at Nationwide Children's Hospital, where she is a gene therapy fellow, and she's focusing on FSHD therapy and development. So Dr. Knox started her MSG ABF fellowship in July, and she's now started her 1st year, and we are thrilled to have you here today, Dr. Knox, to present your talk on post-translational modification of DUX4. Dr. Knox.
Wonderful. Thank you so much for that kind introduction. Let me just share my screen. Wonderful. Okay, let me just minimize. Great. Thank you so much again. It's a real pleasure and honor to be able to present this work to you today. This was actually the first neuromuscular meeting that I attended as a fellow, and so it's just a real privilege to not only be a recipient of the fellowship, but to also be able to present my results here today. So as Dr. Barron mentioned, I am working on FSHD, and today I'll be describing our very exciting preliminary data that's specifically focused on post-translational modifications of the DUX4 protein. So I'll be providing some brief background on FSHD and on this project, and then I'll describe our work looking at DUX4 protein regulation and a novel therapeutic approach that has arisen out of that research. And then I'll describe the next steps that I'm planning to take with this fellowship. So as many of you know, FSHD is one of the most common forms of muscular dystrophy. There are over 800,000 people that are affected worldwide. It's inherited in an autosomal dominant fashion and typically presents in adolescence and early adulthood with asymmetric weakness shown in the pattern in the cartoon on the right. The phenotype is highly variable, even in family members with the same underlying genetics. And unfortunately, there are not currently any treatments, and care is supportive, but therapy development is a very active area of research. We know that FSHD is due to the toxic gain of function of the transcription factor DUX4, which is toxic to muscles when it's misexpressed in FSHD. DUX4 is a transcription factor, and when it's expressed, it leads to the activation of apoptotic cell death. It leads to the expression of stem cell genes. It's also involved in RNA processing, specifically splicing and nonsense-mediated decay. And we also see inhibition of muscle regeneration. As the field has discovered that FSHD is due to a toxic gain of function of the DUX4 protein, this has opened this very exciting era where we are actively developing targeted treatments for FSHD by focusing on the DUX4 protein. And shown in this diagram are the several different mechanisms by which investigators are targeting DUX4 expression, both at the mRNA protein level, as well as downstream consequences of DUX4 misexpression. Currently, there is a clinical trial that is extremely promising for a P38 MAP kinase inhibitor, losmapimod. The Harper Lab has been developing a gene therapy approach for FSHD, which will be a one-time adeno-associated viral treatment with a microRNA that is specifically targeting DUX4. Today, I'm going to present data on a novel therapeutic strategy that we've been taking in the Harper Lab, specifically focused on DUX4 protein regulation. This project focuses on post-translational modifications. So shown in this diagram are the different types of post-translational modifications, or PTMs, that a protein can undergo. And we'll be focusing today on methylation and phosphorylation. So with this project, we wanted to address some fundamental questions. The first is, does DUX4 undergo post-translational modifications, or PTMs? Secondly, what are the functional consequences of this regulation? And finally, can we target PTMs as a novel therapeutic approach? So in order to begin to address these questions, we performed mass spectrometry, and we identified for the first time several PTM sites on the DUX4 protein, which are shown in this diagram. So we've uncovered serine and threonine phosphorylation sites, as well as arginine methylation sites of the DUX4 protein for the first time. In order to determine which of these sites are critical for DUX4 function and toxicity, we carried out an extensive mutagenesis screen. And so we took both a gain of function and a loss of function approach. We've generated phosphorylation mimic and methylation deficient mimic mutants, which are gain of function. And we've also generated phosphorylation and methylation deficient mutants, which are loss of function. We've now screened over 50 mutants, which are different combinations of these residues. And we've uncovered 3 specific mutants, which critically affect DUX4 toxicity. These include 2 phosphorylation mimic mutants with mutations in the residues shown in red, And we've also uncovered a methylation deficient mutant, R71A, which is also critical. And so to explore the function of these sites, we have been exploring their role in DUX4-mediated cell death, in DUX4 target gene activation, and importantly, we've made strides in identifying potential enzyme modifiers which are carrying out these PTMs, as these could be targets for therapy development. So first, I'll present our data on these mutants' role in DUX4-mediated cell death. As I mentioned previously, DUX4 expression leads to the activation of apoptotic cell death, and we're able to assay this in cells using the caspase-3,7 assay. And shown here in black, you can see that when wild-type DUX4 is expressed in this cell line, HEK293 cells, we see high rates of caspase cleavage, which again is a marker for apoptotic cell death. However, if we express either of our three mutants, the 2-phosphorylation mimic mutants or the methylation deficient mutant, we see a rescue of cell death. We have similar findings in proliferating myoblasts. We looked at this using a viability assay with trypan blue counting, and we find that when wild-type DUX4 is expressed, we have decreased viability, but again, this is rescued by each of our phosphorylation, each of our PTM mutants. So we conclude based on this data that the 3 DUX4 PTM mutants that we've identified, the 2 phosphorylation mimic or gain-of-function mutants, and the 1 methylation deficient mutant protect against cell death. And in the next data I show, I'll be referring to the 2 phosphorylation mimic mutants as mutant 2 and mutant 5, just for simplicity's sake. So next we wanted to look at the effect of these PTM mutants on DUX4 target gene expression. First, we looked in HEK293 cells, and we looked at 4 well-validated DUX4 target genes or biomarkers. Our first set of experiments were conducted in HEK293 cells, and you can see that wild-type DUX4 leads to robust expression of each of these 4 known DUX4 target genes. However, the mutants, when we introduce these into cells, we see a dramatic reduction in target gene expression. We find similar findings in proliferating myoblasts. So we conclude based on this data that these 3 DUX4 PTM mutants are critical for DUX4 target gene expression, and this could be some of the mechanism underlying the reduced toxicity. We noticed that when we looked at where each of these mutants were located in the DUX4 crystal structure, that the arginine 71 residue, shown here in blue, is in very close proximity to where DUX4 interacts with DNA. So we postulated that this modification could be critical for DUX4 binding to DNA and transactivation of target genes. And the mutant might be impairing the ability for DUX4 to bind to DNA and activate its target genes. So to test this specifically, we used a DUX4 activated fluorescent reporter system, which has been very well validated in the field. And in this system, we have a known consensus DUX4 binding site fused to GFP. So if DUX4 or DUX4 mutant is able to bind to that region and activate expression, we're able to see green produced in our cells. And so you can see in this lower panel, when we express wild-type DUX4 protein in the system, we see very active, very robust activation of the reporter and many green stained cells. However, when we use the R71A or methylation deficient mutant, we see a dramatic reduction in expression of the target gene. And so we conclude that the DUX4 R71A mutant specifically has impaired transactivation. Finally, we wanted to try to identify the enzymes, in this case, kinases or arginine methyltransferases, which could be carrying out these modifications, as these could serve as therapeutic targets. First, we wanted to identify potential serine and threonine kinases that could be directly phosphorylating the DUX4 protein. And to do this, we use the kinase finder screen. This is an in vitro assay that allows you to screen over 200 serine threonine kinases to be able to directly phosphorylate your substrate. In our case, the substrate was the DUX4 protein. And this data is just showing several of the serine threonine kinases that we identified in the screen that had high activity for being able to directly phosphorylate the DUX4 protein. We then focused our subsequent studies on protein kinase A, or PKA. Protein kinase A is a part of a larger enzyme complex called the PKA holoenzyme, and it contains a few different subunits. We focus specifically on the C subunit, or the catalytic subunit, which is blue in this diagram. And this is termed PRKACA. And again, it's the catalytic subunit of the protein kinase A holoenzyme and is directly responsible for phosphorylating substrates. In our next set of experiments, we wanted to determine whether overexpression of DUX4 with a kinase that can phosphorylate it could also rescue cell death. This would be consistent with our gain-of-function data with the phosphorylation mimic mutant, which showed that a phosphorylation mimic mutant rescued cell death. And that's indeed what we found. So when we express wild-type DUX4, we see high levels of caspase cleavage, which again is a marker of cell death. However, when we overexpress DUX4 with a catalytic subunit of protein kinase A, we see a rescue of cell death. We've also found that if we express both DUX4 and protein kinase A in HEK293 cells and perform an immunoprecipitation reaction, which allows us to see if proteins are interacting in a complex, we find that DUX4 and protein kinase A do indeed interact in a complex. So taken together, this data demonstrates that protein kinase A, DUX4 is a substrate of protein kinase A, and suggests a potential therapy approach where we activate or enhance phosphorylation of the DUX4 protein as a potential therapy. And that's something that I'll be pursuing with this grant. Next, we wanted to try to identify arginine methyltransferases, which are carrying out the methylation of DUX4. It's not currently known if there are any arginine methyltransferases that interact with the DUX4 complex. So in order to tackle this, we took a proteomics approach. We used the assay that's termed rapid immunoprecipitation mass spectrometry of endogenous proteins, or RIME. And with this assay, we combine cross-linking with immunoprecipitation and mass spec, and this allows you to identify transient or more distant interactions. And using this assay, we uncovered PRMT1, which is the most abundant arginine methyltransferase in cells as a member of the DUX4 complex. And we've confirmed this interaction with immunoprecipitation. So we find that we've expressed both DUX4 and PRMT1 in HEK293 cells. They do indeed interact in a complex. So with this data, we've demonstrated for the first time that an arginine methyltransferase is a key component of the DUX4 complex. Based on this series of experiments, we then wanted to explore whether arginine methylation inhibitors could be a therapeutic strategy for DUX4. And this comes from the data that I just showed, that PRMT1 interacts with the DUX4 complex and could be methylating it, combined with our previous data that showed that an arginine methylation null mutant, R71A, protects against cell death. So we've begun to explore this with two specific inhibitors. We've looked at a broad spectrum arginine methylation inhibitor and added increasing concentrations into myoblasts that are expressing DUX4. And we find that at higher concentrations, we see less caspase-mediated cell death. We're also extremely excited to now also be pursuing a PRMT1 specific inhibitor, which at lower doses, we also see this level of protection against cell death. And we recently filed a provisional patent to specifically explore the therapeutic potential of arginine methylation inhibitors in FSHD for the first time. So what I've shown you so far is our data demonstrating for the first time that DUX4 does indeed undergo post-translational modifications. And we've specifically uncovered serine and threonine phosphorylation, as well as arginine methylation as PTM sites in the DUX4 protein. And we've made strides in uncovering how these residues are critical for DUX4 function, specifically in terms of toxicity and target gene expression with the 3 mutants that we've identified. And we're extremely excited to now be pursuing arginine methylation inhibitors as a novel therapeutic approach for FSHD. And with this grant, I'm really excited to be pursuing 2 further aspects of our very promising preliminary results. The first focuses on phosphorylation, and I will be doing experiments to further characterize the interaction of DUX4 and protein kinase A and understanding the consequences of this interaction. And we'll also be exploring kinase activators as well as phosphatase inhibitors as potential therapies, as our data suggests that maintaining phosphorylation of the DUX4 protein protects against toxicity. And then we'll also, in the second aim, be further exploring the methylation inhibitor work, both in vitro and in vivo. So we'll be using FSHD patient cell lines, as well as the iDUX4 inducible cell line, as well as the TIC-DUX4 mouse model, to specifically explore whether methylation inhibitors can protect cells, myotubes, as well as mouse muscles from injury. So we're very excited about these promising results to add to potential DUX4 targeted therapy treatments by specifically looking at arginine methylation inhibitors and kinase activators as therapy approaches. And with that, I'd like to thank my wonderful research mentor, Dr. Scott Harper, as well as members of the Harper's Lab who have contributed to this project. The Freitas Lab at OSU performed the mass spec analyses, and this work has been funded by several different organizations. And I'm so grateful to the Muscle Study Group, the American Brain Foundation, and the AAN for supporting me to be able to carry on this research and provide me with protected time at this critical stage in my training. And with that, I'd love to take any questions.
Thank you, Dr. Knox. That was brilliant. There's one question here from Dr. Lloyd. Are you able to identify DUX4 phosphorylation and methylation in FSH muscle biopsy? He said EGV a pull down, or is expression too low?
It's too low. Yeah, it's something that we're interested in, but as you know, it's very difficult to detect. We do plan to try to look in vivo in our FSHD mouse model. But I think in human tissue, it's just going to be extremely difficult because it's very rarely detected.
And so I think that's the only question that came in. So I had a broader question, and we talked about this a little bit before. So you're clearly focusing on all these post-translational events. Where do you think the money's at in FSHD? Is it going after trying to fix the mutation, or the post-translational event fallout, or is it a combination? And I know it's really way too early, but I mean, how much do you think fixing post-translational events is going to help progression of disease?
Yeah, thank you so much for that question. It's important. As I showed in that diagram, there's several different therapeutic strategies that people are taking. I think the most promising and definitive will be suppressing DUX4 expression with ASOs, and the gene therapy approach that the Harper Lab is developing. And I see this, exciting PTM work as potentially being an adjunct treatment that we could use in addition to a gene therapy or an ASO type approach.
Yeah, you told me that before, so I'm learning. So thank you. Yeah, that's great. All right, there's one more question. Leo Wang asks, did you find P38 being important for phosphorylation of DUX4?
Thank you for that question. So in our screen, we didn't specifically pull out P38 as one of the kinases that had high activity against the DUX4 protein, but we did find a few MAP kinases, so not P38, but other kinases in that pathway that did have higher activity. It's not something that we specifically have explored, but we're working on, submitting this work for a publication. And so it will detail all of the potential kinases that, ourselves or others can begin to explore. It's unlikely just to be protein kinase A. That's just what we're focusing on for now, but great question.
All right. Well, phenomenal work. And thanks for going from coast to coast and finally settling in Buckeye Land in the Midwest with your talented skill set. So
thank you. And thank you for all of your support and encouragement. I really appreciate it.
All right. Okay, thank you. So we will go on now, and I'm going to turn the program over to Dr. Amelia Wilson, who is going to MC the flash presentation. So Amelia, it's flash. I know you're going to keep on time.
Okay. Thank you. And it is my pleasure to introduce Dr. Aikanaga, who will be talking about her xenograph model for IBM.
Hello. Today, I appreciate the organizers giving me the opportunity to present that loss of TDP43 function and removed vacuoles persist after T-cell depletion in the xenograft model of inclusion body myositis. The muscle of patients with inclusion body myositis is characterized by cell-mediated immunity, abnormal mitochondrial pathology, and degenerative pathology represented by removed vacuoles and abnormal protein aggregates, which are positive for P62 and TDP43. The nuclear clearing of TDP43 is also a characteristic finding of IBM patient muscle. Whether inflammation drives pathology or inflammation is secondary to degeneration is unknown. In this study, we aimed to determine the role of T cells in the pathogenesis of IBM. We generated a xenograft model of IBM by transplanting a patient's muscle biopsy into the hind limb of immunodeficient mice. The muscle biopsies degenerate within 2 weeks, and the satellite cells proliferate and differentiate into myoblasts. The myoblasts fuse to form newly regenerated myofibers by 1 month. As xenograft mature, the fiber is enlarged and expression of embryonic myosin heavy chain, which is a marker of early regeneration, decrease. We compared IBM xenograft and control xenograft at 4 months. Looking at these hematoxylin and eosin stains and using human-specific spectrin and lamin AC to mark cell membranes and human myonuclei, respectively, you will see that controller and IBM xenografts both show robust regeneration. As for the number of myofibers, there was no statistically significant difference between IBM xenograft and control xenograft. IBM xenografts show a pathological hallmark of IBM, including endomysial infiltration of T cells, removed vacuoles, and abnormal protein aggregates which are positive for P62 and TDP43, and the nuclear clearing of TDP43. As for the fibers with removed vacuoles, the IBM xenografts show more fibers with removed vacuoles compared with that in control xenograft. We depleted human T cells within IBM xenograft by intraperitoneal injection of anti-CD3 antibody OKT3. The upper row shows untreated IBM xenograft, and the lower row shows OKT3 treated xenograft. At 4 months, there are a lot of CD3 positive T cells infiltrating in the IBM xenograft, and MHC1 upregulation, removed vacuoles, P62 positive aggregates were detected. After OKT3 treatment, the number of the CD3 positive T cells were diminished, and MHC1 upregulation was suppressed. However, we still found removed vacuoles and P62 positive aggregates. The quantification analysis showed that the OKT3 treatment reduced CD3 positive T cells and MHC1 positive myofibers. However, regarding to the fibers with removed vacuoles or fibers with P62 positive aggregates, there was no statistically significant difference between OKT3 treated group and untreated group. Then we checked the abnormal splicing of the target genes of TDP43. TDP43 is an RNA binding protein, and in normal situation, TDP43 contributes to protect cells by ensuring the proper formation of the transcriptome. In the muscle of IBM patient, TDP43 redistributed from its original nuclear location to the muscle sarcoplasm. The finding led to hypothesis that toxic gain of function from cytoplasmic TDP43 or loss of nuclear function of TDP43 contribute to the pathogenesis of IBM. Since TDP43 replaces the abnormal splicing of ACSF2, GPSM2, HDGFL2 genes, the nuclear clearing of TDP43 causes abnormal splicing and generates cryptic exon from these genes. This RT-PCR shows that there are cryptic exon in IBM, but not in dermatomyositis or control. We used 190 patients, including 44 IBM patient samples, and cryptic exon detection showed 84% sensitivity and 99% specificity for the diagnosis of IBM. This RT-PCR shows that both untreated and OKT3 treated IBM xenografts showed the presence of cryptic exons at similar frequencies. From these results, we concluded that cryptic exon detection is a sensitive and specific diagnostic and functional biomarker of IBM. And the depletion of T cells did not alter muscle degenerative pathology in IBM. The formation of limbed vacuoles and loss of TDP43 function represented by the presence of cryptic exons occurs independently of T cells. This work is Kyra Brittson's PhD work, and these people contributed to this work. Thank you so much for your attention.
Thank you. Very great presentation. We have a few minutes for questions if there are any. Let's see, we have one. Caitlin is asking, are the cryptic exons in blood or muscle only?
Let me see. Yes, I have actually detected by immunostaining in the using IBM sample, IBM muscle sample and other idiopathic inflammatory myopathy samples, but regarding to the cryptic exon in blood, I haven't determined it yet, but I think it is a really important point.
All right, we have another. Do you think it's a matter of time if you waited longer, the TDP43 accumulation would have washed off?
Let me see. Waited longer. I think it is a really important point too. So we did the OKT treatment with maximum 8 months. So yeah, I cannot deny, I cannot eliminate the possibility that longer treatment will change the TDP43 accumulation. So this result is we checked maximum 8 months. I think it is an important point.
All right, and it looks like we have another one. Do you think that this TDP43 toxicity could explain the phenotypic spectrum of VCP mutations?
VCP mutation, phenotypic. TDP. So I'm sorry, I do not have the answer for it, but TDP explains. I think it is a really important idea, but I'm sorry, I do not have the answer for now.
Okay, doesn't look like there's any more questions coming in, so we will move on to a presentation by Louie Lee about self-management in neuromuscular diseases.
Okay, I'll just unmute myself and share my screen.
We see it.
And can you see the screen okay?
Yes, we do.
Yeah, fantastic. Okay. So yeah, thank you very much for the opportunity to speak today. I'm a physiotherapist by background, and I'm going to be presenting something a little bit different from what we've heard so far, which is some of the preliminary findings from the first study in my PhD work, which is a qualitative exploration of self-management from the perspective of people who live with neuromuscular conditions. And hopefully you will find it interesting. So self-management is described as any form of formal education or training for people that live with long-term conditions that focuses on helping people to develop the knowledge, the skills and the confidence to manage their own health and care effectively. So current understandings very much advocate a collaborative approach where responsibility for disease management is shared between the patient and the clinician. And current approaches really respect the fluidity of context and the need to consider social determinants such as ethnicity and socioeconomic background. And these things can all have an impact on the way that an individual manages their condition. So although exactly what constitutes a good self-manager remains the subject of much academic debate, skills such as problem solving, reflection, taking action, self-discovery, and collaboration have all been repeatedly associated with improved self-efficacy and the ability to manage the challenges of living with chronic disease. So as a chronic care model, self-management support is now part of routine care for long-term conditions such as diabetes and hypertension. It's improved the quality of life for people with many conditions, including depression and long-term pain. And it now very much constitutes a key policy focus in the UK. And so unsurprisingly, there's been increasing interest in tailoring self-management support to neurological patient groups, things like MS and Parkinson's, for example. But despite this, there's a real striking lack of evidence exploring self-management support in people that live with a neuromuscular condition. Which brings me on to the overall aims of this study, which was to explore the insights of people living with neuromuscular disease on what successful self-management actually means and looks like. If there are any barriers or challenges to self-management that they experienced, preferences for how people would wish to receive self-management support, and then the outcomes and mechanisms for delivery and evaluation that would be acceptable to people that lived with one of these conditions. And we're going to explore this through a series of semi-structured interviews. So to date, we've had 24 participants out of a target of 30, and the inclusion criteria have been deliberately broad so that perspectives from a range of different conditions could be examined. And this type of approach is commonplace in qualitative research. The sampling for this study was purposive to ensure a breadth of people with a range of diagnoses and ages. And the interviews were audio recorded, anonymized and then transcribed verbatim before a thematic analysis was undertaken to explore the emerging themes. So in this study, social cognitive theory has provided a theoretical underpinning, and this provides an explanatory theoretical framework of positive behavior change. So to develop the understanding further, I've mapped the emerging themes from the data to the biopsychosocial model, which is now well established as a cornerstone of the UK healthcare system. So the process of mapping the subordinate themes and codes to the model has culminated in the development of 3 overarching themes that really seem to link into 2 fundamental questions, which were what keeps me going and what holds me back. And these 3 main study themes were always adapting, it's not just physical, and support systems. So unfortunately, there won't be time to delve really deeply into these themes, but the accounts of the interviewees are providing us with valuable data that will help us to shape and evaluate future self-management support. So just for a brief example, when asked for their priorities about how we could improve self-management, all 24 participants mentioned the need for increased psychological support. So also many patients described the complex 3-way relationship they had between themselves, their families and their healthcare providers. And this indicated a clear rationale for the consideration of strategies that could augment collaboration between these key stakeholders when designing and delivering self-management. Another example of how the themes link to the delivery of self-management is illustrated through participants' descriptions of goal setting, which is a key facet of many self-management programs and rehabilitation in general. So interestingly, the data indicated that this was often problematic when disease trajectory and progression was uncertain. And many participants cited this as a frequently recurring psychological stressor, leading to reduced participation and access to their communities. So that's really just an overview of the themes that are starting to emerge from this work, but it's an indication of how these preliminary findings are providing a rich insight into the lived experience of neuromuscular disease. Recruitment's ongoing, so we certainly can't draw any final conclusions yet, but the account so far highlights some of the unique strategies that people use and increases our understanding of their shared experiences and shared values and how they wish to be supported. The preliminary data clearly link to established techniques for supporting self-management with implications for approaching this in clinical practice and for design considerations for future research. And on that note, data from this study has been used to help shape the design of a hybrid evaluation of a new co-designed self-management support program for people with neuromuscular disease, which I'll be discussing a little bit in a presentation later today. And so I think that's as much as we've got time for on this. So thank you very much for listening, and I'll now take any questions if there are any.
Yes, thanks. I guess we're just waiting for any questions that may come in. Seems like a really great research on helping us care for our neuromuscular disease patients. Doesn't look like there are any questions, so we can move on to our next presentation by Megan Marino. She'll be talking about some clinical trial readiness for a proteinopathy. Megan, ready for you.
Let me see. Okay, perfect. All right, thank you so much. And I'm going to share my screen with you. All right, can you see?
Looks good.
All right, perfect. All right, so thank you, everybody. Thank you for allowing me to speak and giving me the opportunity to present our exciting work in establishing clinical trial readiness for valicin-containing protein multisystem proteinopathy. So this is a one-year prospective study that our team at Nationwide Children's Hospital is doing in collaboration with Cure VCP Disease, which is a patient advocacy group. Our trial design incorporates both remote and on-site study visits. And today I will be focusing on presenting the baseline data. So this includes two-day on-site visits and two-day remote visits. So 4 total baseline visits for each subject. For each of these visits, subjects completed a battery of testing that you can see down here, including a series of patient-reported outcome measures and motor function testing. And the motor function testing was completed as able based on functional status, functional abilities, or visit type, so remote or on-site. And what I really want to highlight is that in partnership with Cure VCP, we pulled together and we were able to enroll 24 patients for a total of 96 study visits in just 4 months, which is pretty exciting, especially considering the pandemic. So looking at what our baseline functional assessments tell us, we know that VCP MSP is a disease of heterogeneous clinical presentation, and this is reflected well in the baseline performance on both the North Star assessment for limb girdle type muscular dystrophies, or the NSAD, and the performance of upper limb, or the PUL. Neither assessment had a correlation with age. However, when we divide the full cohort into smaller cohorts based on cluster genetic mutations, here we find that there is a significant difference in performance between groups on each assessment. And this kind of supports the thought that, that specific mutations in the VCP gene may be an influential variable in disease presentation and disease progression. So the 100-meter time test is an assessment of ambulatory function where an individual goes as quickly as they possibly can for around a 25-meter track for a total of 100 meters. This was something that we had subjects complete during on-site visits only. In our entire cohort, only 4 subjects were unable to complete the assessment. And not only do we find down here, we find kind of a general stability in walking speed across the entire cohort, but also when analyzing performance and performance lap time, only those with the slowest walking speed, so those up here, demonstrated any kind of fatigue during the duration of the assessment. Time functional tests are also able to tell us quite a bit, not only about our cohort and how they perform, but also about the feasibility of testing types, so remote versus on-site. So while assessments such as the time to rise, the 10-meter, and the timed up and go or the tug, all 3 of those are able to be completed remotely. However, of all of the subjects who were able to physically complete the 10-meter, only about half of them actually had the space in their homes to do so. So space and living style are considerations when selecting measures that can be performed remotely in a clinical trial. Performance-wise, half of our entire cohort was able to perform the time to rise, and only about a quarter were able to complete the tug, suggesting that this may not serve as a utility as a motor endpoint in a clinical trial. The forced air climb was able to be performed by most of our group. However, this assessment is limited to on-site visits only. So moving on to our patient-reported outcome measures, or PROs. At this time, there are no PROs that are validated in VCP MSP, despite the FDA's, especially for people in the US, despite the FDA's emphasis on including the patient voice in clinical trial outcomes that can help kind of support labeling claims. So what we did was we gathered a selection of PROs, both composite measures, so those that cover multiple domains of function, and single measure PROs, or those that focus on one domain of function. So those are the ones that we selected reflect symptom clusters that are common in this disease. So what we found is that the IBM-FRS, or the Inclusion Body Myositis Functional Rating Scale, from the composite measures here, or the PROMIS Mobility from the single measures here, those were the best and provided the best variability in scoring, again, closely reflecting the clinical heterogeneity of the disease. However, we also see that with the Communication Participation Item Bank, the EAT-10, which is a swallowing screener, and the Speech Handicap Index 15, of all those 3, there is a bit of a ceiling effect that we found in this cohort. And however, they still do provide us with some good clinical information, such that about a quarter to half of the participants report at least some difficulties with communication, speech, and or with swallowing. So with 4 total baseline visits, we have a good amount of data to start looking at the interday reliability of these assessments in this cohort, both at a group level and at an individual level. So if you see here, our group level reliability is excellent for all of our functional assessments, regardless of visit type. So this is for the on-site visits and for the remote visits. And they were strong to moderate for our PROs with ICCs of 0.72 to 0.99. So group level reliability is excellent. However, if we look at the individual level, we can notice that on some assessments, such as here on the NSAD, variability has this potential to be pretty significant between baseline days compared to such as like the performance on the 10-meter here. This kind of supports supports our choice to have at least 2-day baseline visits to have capture the best maximal function. One thing that we did find also that was pretty interesting is using the patient global reported impression of change scale. All subjects who reported improvement compared to baseline day 1 were following on-site visits, and individuals who reported a worsening of disease severity, we're following remote visits. And I think this gives some good consideration to a visit type in trial design. So why is this? Is it a coincidence, or do people feel more comfortable, confident, and safer when performing difficult tasks in a clinical setting with a specialized trained professional? It's certainly not conclusive, but it's something that's still, I think we found that's pretty interesting. So in summary, the clinical outcome assessments that we used, that we selected appear to have and quantify abilities across a population with a bit of heterogeneity. Not all of the COAs that we selected were able to be completed in the home, even if the subjects were able to complete the assessments. There was excellent group retest reliability. However, there was some variability in individual performance between days. And so further efforts, we're going to look at longitudinal testing to see if the clinical outcome assessments and the PROs were sensitive to change over time. And how do we quantify meaningful change on the motor outcome measures? And that is our team, and thank you so much.
Thank you, Megan. Great presentation and impressive work in a short amount of time. We have a minute or two for any questions. Is there any? I wanted to ask, based off of some of the barriers you identified for remote assessments, did you find that any were particularly better or more meaningful for this population?
So I think some of the discrete tasks are easier. If we are doing things like the NSAID that require specialized equipment, it just requires that we ship the equipment to the home, or like the performance of upper limb. It translates really well into like a remote testing scenario, but you still just need to provide the very specialized equipment.
And then we have one more question. Can you comment on the proportion of phenotypes that were enrolled, mainly IBM, ALS, FTD?
Yes, so and that's for a whole different presentation on a different day, but yes, it was primarily, most of our individuals reported IBM type symptoms, not so much ALS, and very little with FTD type symptoms. However, we did also find that although nobody really reported peripheral neuropathies on our exam, we found that a majority of our subjects still had like a peripheral neuropathy that was unreported.
Okay, great. So that is our time. So any more questions can be directed directly to Megan via the chat. And we will move on to a presentation about COVID-19 in mitochondrial disease by Dr. Pisamingilio. Sorry if I pronounced that wrong.
Thank you. Okay. Okay, can you see my screen?
Yes, we do.
Okay, perfect. So thank you for this opportunity. I'm a clinical research fellow and a PhD student in mitochondrial diseases at UCL. And today I'm going to present you the results of our international study about COVID-19 outcomes in primary mitochondrial diseases. So as you know, in general, people with neuromuscular diseases may be at high risk from COVID-19 due to the possible presence of additional risk factors. And people with mitochondrial diseases, due to the multisystemic involvement and the possibility of metabolic decompensation due to intercurrent illness, were grouped into the clinically highest risk category by both the NHS England and the CDC. And they were advised to shield during the pandemic to avoid complications from severe COVID-19 illness. So in this study, we wanted to understand what are the risk factors for COVID-19 hospitalization in patients with mitochondrial diseases, especially given the fact that this is a heterogeneous group of diseases with a variable clinical involvement. So this is an international registry-based study. 79 patients with mitochondrial disease and COVID-19 infection were reported. And the main outcome was the hospitalization status, yes or no. And patients' general informations and details about the mitochondrial diseases were collected. Moving now to the results, you can see that 79 patients from 10 different countries were recruited, and their mean age was 41.5 years, so quite a young cohort. Most patients had a genetically confirmed diagnosis, but there were 11 patients where the diagnosis was genetically unconfirmed. Of those with a genetic diagnosis, as expected, mitochondrial DNA mutations were more common than nuclear DNA mutations. And then to evaluate the severity of the mitochondrial disease and patient's disability, we have used respectively the Newcastle Mitochondrial Disease Adult Scale score and the modified ranking scale. So most patients, 95%, had COVID-19 symptoms. In 54 patients, hospitalization was not required, but in 25 patients were hospitalized. And in 4 of them, mechanical ventilation was required. 48 patients fully recovered from the infection, and unfortunately, 3 patients died. 28 patients resolved, so the infection resolved, but they continue to have sequelae after the infection. In particular, they had deterioration of pre-existing neurological symptoms, worsening of fatigue in isolation, or development of new symptoms. The most common comorbidities we have seen in our cohort were lung disease, mitochondrial diabetes, hypertension or other cardiovascular diseases, obesity, and neurological involvement. Here you can see the results of the univariate analysis. We have divided patients in those that were hospitalized and those that were not hospitalized. And you can see that there were more hospitalized patients within those that had severe symptom at the NMDAS score, those that had a severe, moderately severe, or severe disability at the modified ranking scale, those that had lung diseases, neurological involvement, or more than 4 comorbidities. And in the multivariable logistic regression analysis, only lung disease was an independent risk factor for hospitalization with an odds ratio of 7.66. So in conclusion, our study highlights some risks and outcomes for patients with mitochondrial diseases. And our findings will enable risk stratification and informed management decisions in this patient population. In summary, our data show that risk factors for hospitalization among people with primary mitochondrial diseases were the presence of lung disease and neurological involvement, an increased number of comorbidities, and a worse baseline functional status. Interestingly, we didn't find an impact of age in our cohort as for the general population, and 35% of our cohort has ongoing sequelae after the infection. There are some limitations. The main limitation is that this is a registry with a voluntary nature, so there can be a bias towards more severe COVID-19 infections. And further correlations with genotype and phenotype were not possible. However, those studies are important because they can highlight things that can be improved to optimize care for these patients in future respiratory pandemics. So I'd like to thank all colleagues reporting cases to the database worldwide, and of course the neuromuscular team in London that has supported me during this project. Thank you.
Thank you. Do we have any questions? Well, it doesn't look like there are any coming in. Thank you very much. Very interesting and definitely good information for those of us caring for those type of patients. We will move on. We're bringing Lee back to talk more about his work on self-management in neuromuscular.
Okay, can you see that screen okay?
We're good.
Yeah, fantastic. Okay. So yeah, thanks for the opportunity to speak again. So following on from my presentation previously, I'm going to be discussing the protocol for the second main study of my PhD, which was informed by that qualitative work. And it's a hybrid 2 study exploring the feasibility of delivering, evaluating and implementing a new self-management program for people living with neuromuscular disease. So earlier I discussed the substantial evidence base for self-management for support and its prioritization as a key public health focus in the UK, and also the striking lack of research exploring how it's enacted in the context of people living with neuromuscular diseases. So in response to this, we've used co-design methods to adapt an existing self-management program to meet the specific needs of people living with one of these conditions. And this program was called Bridges. It was originally developed for people living with stroke. And Bridges is a self-management approach that has evolved out of a 12-year program of research. And it's an evidence-based unifying framework for personalized self-management. It very much focuses on the quality of interactions required to support knowledge, confidence, and skills in people living with long-term disease. And it involves a series of training workshops for healthcare professionals to help them to support people to self-manage with a chronic condition. It's got a core ethos of co-design and co-production, and there's now an accumulation of evidence for Bridges supporting its use in a range of different neuro rehab settings, including stroke and traumatic brain injury. And we now need to evaluate this new tailored version of Bridges in the neuromuscular population. And very importantly, the specialist clinical setting of Queen Square in London, where I'm based, as we know that self-management can be very context specific. So another consideration for us in this study was implementation. So the substantial gap between the healthcare that patients actually receive and the practice that's recommended in the literature is well documented. And implementation of self-management support in routine practice is particularly complex, and there are potential barriers at the level of the patient, of the professional and the wider organization. And really there's a need for further research to understand how provider burden can be minimized and how self-management programs can be made more widely acceptable. And with a complex intervention like this, it's important to consider implementation aspects early on in the study. So it's widely accepted that the use of theory is crucial to implementation efforts. And in this study, we'll be using normalization process theory, which has been used effectively in previous trials of self-management. So as I've mentioned already, in this study, we're using a hybrid design, which involves a blending of traditional research methods with implementation research, allowing us to interrogate the implementation aspects of the trial in a more structured, coherent and rigorous way, whilst simultaneously gathering valuable data on the clinical intervention itself. So there's now a growing body of evidence to suggest that these type of designs can speed the translation of knowledge into practice, and there are 3 main types. And so for this study, we'll be employing what's called a hybrid 2 approach, which provides a dual focus, which will allow us to test the feasibility of the neuromuscular Bridges intervention, this self-management intervention, whilst simultaneously testing the feasibility of a combination of implementation strategies. So testing the feasibility of implementation strategies is increasingly viewed as important, as many of these strategies employed in effectiveness trials are not always feasible in real world settings. So that could be things like paying participants to take part or taking on extra staff, etc. So originally an RCT was planned for this work, but we felt that randomization at the patient level could be problematic due to the potential carryover effects of clinicians transitioning back and forth between providing routine care and then the Bridges intervention itself, and that could lead to an intervention leak. So therefore it was agreed that it would be just cleaner to do a cohort study with pre and post measurements. It may be a lower design in the traditional hierarchy of evidence, but a clean, well-conducted cohort study could be stronger than a feasibility RCT with intervention leak problems. The hybrid design would then allow us to deliver an implementation strategy package concurrently and explore those kind of aspects of the trial as well, which is, like I've said, such an important factor when considering complex self-management interventions. So before the study commences, Queen Square Therapy and nursing staff will receive the co-designed training on how to deliver the Bridges intervention. Then a target sample of 60 people with a range of different conditions will be recruited from the neuromuscular clinics at Queen Square in London. The intervention itself will be delivered through one-to-one sessions as part of routine therapy and nursing appointments with co-designed paper and digital tools to reinforce the content. And then 3 measurement sessions will take place. So we'll have one before the intervention, directly afterwards, and then 3 months post. Where we'll collect outcome measures to evaluate the intervention's effect on a selection of established self-management specific outcomes. And these outcomes were recommended in the literature, but also talked through with the study's PPI group, the patient and public involvement group, and crucially using that qualitative data from the first study to inform what outcomes we were going to measure, to making sure that these outcomes were important to the patients that were going to be taking part in the study. Then data on implementation will be gathered concurrently, and implementation outcomes themselves will be measured through qualitative interviews, through surveys, through administrative data, and through a notes audit. So in terms of the deliverables, this study is hopefully going to be providing data on the feasibility of both delivery and implementation of this new intervention. And the feasibility testing of delivery will provide us with data on the acceptability of the intervention to both clinicians and participants, which will be important if it is going to be rolled out to other services. It will give us insight into the demand for the intervention within the specialist service, the data on participant recruitment and retention, data on acceptability and performance of the candidate outcome measures, which could potentially inform our future larger trial, and then the outcomes relating to the implementation strategy package. This will be data on things like the fidelity of both the implementation process and the intervention itself, and also insights into barriers and facilitators to the implementation strategy, its acceptability to the clinicians, its appropriateness and its practicability to the specialist service, and finally its effects on adoption rates. And although this is quite a complex trial, that's probably all we've got time for in this context. So I'll say again, thank you very much for listening, and I will take any questions if there are any.
Yes, thank you. Any questions for Louis about this? So is the Bridges program something that anyone or any clinician can access, or do you need to get the training, or is it?
So it requires training. So it's a training program for clinicians, which involves basically helping them to modify communication styles and providing them with resources and skills to be able to support patients with self-management. But it does require people to undertake the Bridges training to become kind of qualified in the approach.
And it looks like you've been using nursing staff as the ones providing.
So we've been, the people that will be taking part in this study will have therapists, so there'll be physiotherapists, occupational therapists, and nursing staff. But Bridges is something that can be used by, by doctors, by speech and language therapists, right across the board. It's really kind of trying to make self-management business as usual, which is something that's very much a key policy focus over here in the UK at the moment, is trying to embed it within our healthcare systems, and Bridges is kind of all about that, really.
Yes, seems very important for patient care. Any other questions? Okay, it looks like we're a little ahead of schedule, but we'll keep moving on. We have Megan back to talk some more about clinical trial readiness in FKRP related muscular dystrophy.
All right, everybody, I am back. Let's see. And we're going to switch gears just a little bit and talk about, can everybody see the
Yep, we see them.
presentation? Excellent. Okay, so I will be presenting some baseline data on the multi-site international GRASP consortium study that's focused on clinical trial readiness in LGMD-R9 or FKRP related muscular dystrophy. So subjects with genetically confirmed LGMD-R9 completed 2-day baseline visits with an option for remote or on-site visits. At this time, 83 subjects had been enrolled, and you can see kind of the demographics here. And of those that were enrolled, 13% of the baseline visits were completed remotely. Subjects were then stratified into 2 cohorts based on their performance on the 10-meter time test. So those that completed the assessment in 12 seconds or less were placed into cohort 1 here. And then those that either completed the assessment in greater than 12 seconds or were unable to complete the assessment were placed in cohort 2. Cohort designation determines which battery of functional assessments were performed at each visit, which you can see down here. So the performance of upper limb or the PUL, the 9-hole peg test, and the North Star assessment for limb-girdle type muscular dystrophies, or the NSAD, were 3 assessments that were completed across cohorts. So we'll take a look at these first. So first, looking here at the PUL comparison in performance between cohorts, we can see that there appears to be a ceiling effect here in performance of cohort 1, with only 9 out of 51 individuals scoring below a 90%. And this suggests that maybe the PUL, it may not be sensitive to change in these less affected individuals. We see similar results here with the 9-hole peg test. And while we found that there was a significant difference in performance between the groups, this differentiation can really only be seen here in those that are the most affected. In contrast, a baseline performance on the NSAD over here shows not only a good variability in scoring, but also shows a good division between cohorts based on the inclusion criteria or the designation criteria. And it suggests that this could be a good measure that can be used to distinguish function across functional abilities and levels of disease progression. So now looking at our time functional tests, and these were the ones completed by cohort 1, we can get a good idea not only how they respond to varying levels of abilities in our strongest group, but also about the feasibility of using them again on remote visits. So 98% of cohort 1 was able to complete the 4-stair climb. However, this was limited to on-site visits, and this is due to heavy, the standardized equipment that we use, which is heavy and expensive. That's limited to a hospital setting. Also, if you can see here, this clustering of points at the top shows that there isn't a lot of difference in performance and kind of trends towards a ceiling effect. Time to rise from supine had a strong to moderate correlation with age, and it was able to be completed remotely. Making it appear that people seem to lose this ability quite quickly, and it may not be a good endpoint for trials of longer duration. The TUG also shows a moderate correlation with age, has a good distribution in performance. It can be completed remotely, and most of cohort 1 was able to complete the assessment. And this suggests that it might be a promising in defining performance within this group. However, it is important that we see how it responds to change and how sensitive to change it is over time. The 100-meter time test, again, only completed by cohort 1, shows a good distribution in scores in the stronger, younger, and ambulatory ambulatory cohorts down here, and it does not have a ceiling effect in this group. And this is important because it allows individuals an opportunity to have measurable change or improvement with treatment. We can also see over here, as we move down the age line, we can see a general stability in ambulatory speeds, and suggesting that individuals may maintain the ability to walk for quite some time. However, they will do so at a relatively stable pace. Finally, and importantly, these 2-day baseline visits give us information on variability in performance at a group level and at an individual level. Everybody knows that human performance is variable, whether you have the neuromuscular disease or not. So in clinical trial design, we want to limit as much variability as we can by selecting measures that are consistent and stable between days. The test-retest, looking at the group level, the test-retest reliability was excellent for all assessments between days for both on-site and remote visits with ICCs of 0.84 and above. And then looking a little bit further, we can use these ICCs in a distribution-based method. We can start to look at what is the minimal detectable change, or what is the minimal amount of measured change within this cohort on each assessment that reflects true change, and it is a change that is outside of error or variability. And that's here, but preliminary look at that. And then, so group reliability is strong. But then moving over and looking at individual variability, we see that while there is no systematic difference in performance between days, meaning that proportionally subjects, the proportion of subjects that improved on baseline day 2 is the same as the number of subjects that declined on baseline day 2, there is still a noticeable variability in performance in individuals. And this suggests that these 2-day baseline visits may be preferable to capture maximal functional performance, especially in trials with limited enrollment. So in summary, the 12-second cutoff on the 10 meter that we used to separate the cohorts did so well, as we saw on the NSAID. There are some potential ceiling and floor effects that we found with our discrete tasks. Again, our remote assessments may be feasible with necessary equipment and training. And on average, group performance was stable on functional assessments across baseline days, but 2-day visits may be useful, again, to understand individual variability and capture maximal performance. And longitudinal data collection is ongoing. And yeah, so I want to thank the GRASP Consortium and all the collaborators for giving me the opportunity to present this data, and we can open up to any questions.
Great, thank you, Megan. Any questions for Megan? Something I was wondering, Megan, you talked about the ceiling effect of the pole and the 9-hole peg. Do you think there's a need for a different sort of measure for like upper extremity, or do you think it's fine to just rely on your other functional measures?
Well, I think what that tells us is that perhaps upper extremity function declines after gross motor function. So if we use all of the assessments that we have to kind of look if there's any variability in upper extremity function and we don't find any, then maybe that suggests that that is a measure that can wait until later in disease progression.
All right, any other questions? All right, well, thank you to Megan and thank you to all the other speakers in this segment. We have a break. We'll have about a 15-minute break and we'll come back at 11:15. And our break is sponsored by argenx.
That was great. And Mike, why don't you unmute too?
Yeah, I'm here.
Yeah, I told the group earlier that you had to miss the first part of the meeting because your daughter graduated from Oxford today. That's pretty darn cool.
Yeah, I'm sorry. Yeah, I'm sorry I wasn't here, but it was a once in a lifetime.
Yeah,
we're very proud. Yeah, thank you.
That's great. So what a great day. The whole thing was good. You know, updates on our MSG studies, some great invited speakers. our amazing fellow talk, the flash presentations, and then the sponsors presentations, all just are terrific. They really fit a theme, show that everything is moving forward at just lightning speed. And I couldn't be more pleased with how it all went. I want to thank everyone who presented today. And I particularly want to thank our facilitators, Amelia and Shafiq, for keeping things on time. You guys did a great job. We are going to go to these rooms here in a minute. Gil's going to show us how to do it. Just again, we did it yesterday. That was a lot of fun. Anyone have anything they want to share with the group though about today?
Mic channels are open, so anyone can unmute.
All channels are open. Okay, you can unmute if you want. Any thoughts? All right, Liz. Yeah, go ahead, Mike.
Yeah, no, I heard most of I missed the first couple of talks, but I just want to echo your points. And I particularly want to stress the power of connection that MSG is now forming between colleagues in industry who are doing really great science and our clinical academic community. I think the MSG is really ahead of many organizations in actually forging genuine relationships and having our colleagues from industry present the science of what they're doing. And I think that's really, really important because, this is a partnership. We're not going to crack these diseases except through this partnership working. So I think that's a really important feature of the MSG. And just to echo your thanks to all of the speakers today, as well as our colleagues from industry.
And you did miss the first couple parts where we had Jim Dick gave an unbelievably great talk on CISP and CIS+, and then we had other peripheral neuropathy talks. And I hope, Shafiq, you and I got across to our nerve colleagues that this is a home for them as well. It isn't your grandfather's MSG anymore, or it's for everybody. Dr. Mato, you're smiling. Say something, Tony. Yeah. How are you? I didn't see you reading the newspaper today.
I was
yeah, yesterday. Oh, reading neurology. Yesterday he was reading the one of the newspapers while the camera was on him. All right.
Thank you for the nice comment.
I don't read intraoperative monitoring, Rick, during meetings.
I've given up intraoperative monitoring. I'm thinking I may need to start it again to jumpstart things on you. Jim, go ahead and say something.
I was just saying thank you for the nice comment. It was nice to be here, and I do think we had some good nerve sessions today.
Yeah. Thank you, Jim. That was really good.